Good morning. Can you hear me?
Yes, we can.
Okay, thank you. Madam Registrar, members of the organizing committee of this ethics and mental health webinar, other members of the board of the Medical Council of Jamaica, colleagues, good morning, Happy New Year, and a warm welcome to the Ethics and Mental Health webinar. Today's webinar will be done at no charge, and that is our way of sharing the burden of the unavoidable high cost of practicing medicine. The topics are timely and well thought out. The faculty is a high-class one. In fact, half of the presenters are my classmates. I am sure that at the end of the webinar, your knowledge in these areas will be enhanced and it will be a day well spent. Sit back, relax, and enjoy the webinar to come. Thank you.
Morning.
Good morning. Morning, Dr. Ekar.
Okay, that was a very quick, very spicy introduction. Good morning to all our colleagues who are online. Thank you for spending time with us on Sunday with another Medical Council ethics seminar. And as our chair said, this is going to be a really thought-provoking seminar with a high-quality faculty. Lots of things that we are interested in talking about today. And before we start, I want to lay down some housekeeping rules. We're happy to see everybody. We're having the start of a new year, but the chat is going to be reserved for questions. So please, while we're happy to see you, we're going to reserve the chat for the questions. The number of CMEs from the session is 4, 2 CME for ethics, 2 CME for mental health. And you're going to be asked, for those people who are online, you are going to be asked to make sure to register with your names, and you will receive your attendees on YouTube who require CME must indicate so in the YouTube chat, include your names so we are sure you're attended, and CME's inquiries can be addressed to info@medicalcouncilgp.com. And we'll repeat this throughout the presentations. So let's start off. We have a high quality faculty. We're looking forward to some insightful presentations. And our first speaker is going to be our own Dr. Peter Glegg. Now, Dr. Peter Glegg is a medical doctor and a former senior resident in general surgery at the St. Anne's Bay Hospital. He's an attorney and serves for 7 years as a senior legal officer / medical legal consultant at the University Hospital of the West Indies. Dr. Glegg has proven his worth many times in assisting us in difficult decisions. Dr. Glegg is currently the UWI Mona Campus Legal Officer, as well as, listen to this carefully, he is a university public orator. That's no small feat, and I think he deserves a round of applause. He is a lecturer at the Norman Manley Law School, as well as an adjunct lecturer at the University of Technology and at UWI Mona Campus Faculty of Law. Dr. Glegg, our university orator, welcome to the MCJ Ethics Symposium, and we look forward to hearing your talk on disclosure and apology following an adverse event. Over to you, sir.
Good morning, Dr. Eckhart Stewart. Good morning, everyone. Thank you so much for having me. I'm so happy to be able to present this very timely um, presentation on this very important topic. If you could allow me to share my screen, sharing privileges, please. Um,
You have, just go right ahead.
Thank you very much. Okay. Uh, Let me just start from the top. Uh, okay. All right. Okay, so when I was thinking about this presentation, I remember in my final surgical clerkship in medical school, Dr. Derek Mitchell, who was consultant, I think, on Firm C at the time, he suggested to the senior residents they read this book called Forgive and Remember. I must admit that I never read the book, but just the topic of the book in and of itself was instructive to me. I suspect that if something bad should happen, we would that the patients and their family would forgive us, but we would always remember. Or is it that our colleagues should forgive us, or we should forgive ourselves, but always remember? In such light, this discussion, I wanted to start quickly with some scenarios. So, and for discussion purposes, let's look at the first scenario. So the consultant on the
Dr. Glegg,
pediatric ward.
Dr.
Yes,
Glegg,
ma'am.
my sincere apologies for interrupting you. Want to put yourself on slideshow so we have the slides nice and
Slideshow.
big.
Let,
Perfect. Thank you
let me,
so much, sir.
okay.
Great.
Just confirm that you see this change in the slide. Have you see
We're
this
at
slide
scenario
change?
2. Go back to
Good.
scenario 1. Good.
Excellent.
Perfect.
Good. So, and these are all made up scenarios, but the consultant on the pediatric ward at the Duncan's General Hospital calculates the dose of a drug for a 13-year-old female patient. The drug is administered by the junior resident based on the dosage in the treatment chart, and the patient develops a severe reaction, ending up in the ICU for a week. It was later discovered that the calculation was incorrect. The mother accosts the resident on the corridor, demands to talk with the resident, and wants an apology. The resident refuses to meet with the mother on the corridor and refuses to apologize, saying that he did nothing wrong. Second scenario, at the downtown regional hospital, which is located beside a major garrison community, the only daughter of a powerful don, whose name is Leon Paul, is admitted with eclampsia. An emergency section is done, and the baby is healthy, but the mother remains in a coma. The residents of the community block the roads in protest, and the don demands to know the name of the doctor who performed the section. Scenario 3, a 30-year-old male presents with an inflamed pelvic appendicitis. Surgery is done successfully, but he develops a urethral stricture after being catheterized for the operation. He will now have to wear an indwelling catheter and needs a TURP to fix the situation. His lawyer comes to the hospital demanding an explanation. And I'm sure all of these scenarios rings a bell with anyone who's been practicing medicine for more than 6 months. Okay, so let me just quickly move to some definitions so we can be in a better position to have a discussion. Quickly speaking, in order for you to have a successful lawsuit for negligence, you have to prove 3 things to the court. You owe a duty of care to the patient, and that's a given. We never argue about that. That you have breached this duty of care, whether by the error of commission or the error of omission, and that the harm that resulted from this breach is significant, or this breach has caused some harm to the patient. Now, this case was a significant case, and it kind of speaks to the kind of situation that we have to deal with sometimes. This case made national and international, media presence. And I must say, and I think I can state at this juncture that, there are some persons who fed a lot of false information to the media It was sent to the DPP to rule to see if there was clinical negligence, which of course the DPP ruled that there was no criminal negligence in this matter. And I take this document from the Gleaner because I want to show that this is a public document and not internal private documents that I'm sharing. But according to the DPP, the non-medical negligence has been judicially decided in the seminal case of the Queen against Bateman, and aptly summarized by Lord Hewitt as follows. If a person holds himself out as possessing a special skill and knowledge, and he is consulted as possessing such skill and knowledge by or on behalf of a patient, he owes a duty to the patient to use due caution in undertaking the treatment. If he accepts the responsibility and undertakes the treatment and the patient submits to his direction and treatment accordingly, he owes a duty to the patient to use diligence, care, knowledge, skill, and caution in administering the treatment. Of course, the DPP continues to say that there's no contractual relationship that is necessary. So meaning that if you see someone in the parking lot, in the corridor, in the supermarket, you still owe them that duty of care. Now, one of the things that is significant in this ruling is that the jury should not exact the highest or a very high standard. So they shouldn't compare it to Einstein or a rocket scientist, nor should they be content with a very low standard. The standard that is required is a fair, reasonable standard of care and competence. Fair and reasonable standard of care and competence. This case is also significant with the Northeast Regional Health Authority because I think this is one of the cases that made me decided I had to go study law. Where the court said the standard of proof which the laws imposed on the infant plaintiff was that they required in civil cases, namely proof on the balance of probabilities. What this says, ladies and gentlemen, is that the bar is set very low when you're doing negligent suits. It's just based on the balance of probabilities, not based on beyond a shadow of a doubt. So therefore, the bar is set very low. Now, this is the point I want you to pay attention to. The judge says in that case, in my opinion, allegations of negligence against medical practitioners should be considered as serious. Firstly, the defendant's professional reputation is under attack. Finding of a negligence against him may jeopardize his career and cause him substantial financial loss over many years. Secondly, the public interest is put at risk. Therefore, if courts make findings of negligence on flimsy evidence or regard failure to produce an expected result as strong evidence of negligence, doctors are likely to protect themselves by what has now become known as defensive medicine. And that's where Jamaica is going, by the way. That is to say, doctors are now going to start adopting procedures which are not for the benefit of the patient, but safeguards against the possibility of the patient making a claim for negligence. So one of the points I want you to take is the issue of that you want to sue the person on flimsy evidence because the expected result was not achieved. So therefore, what the court is saying here, one, you have to be cautious. The court is cautioning itself not to give a judgment against doctors for medical negligence unless it's, and it should be taken very seriously. But also, is that what the court is saying is that because you do not get the expected result, it does not automatically mean that there is negligence. So when you have an adverse event, ladies and gentlemen, an adverse event does not equate to negligence. And I'll look at that a little later on. Now, this is a key shot. Medical practice these days, the court continues, consists of the harmonious union of science with skill. Medicine has not yet got to the stage, and maybe it never will, when the adoption of a particular procedure will produce certain result. Many times patients have a problem when the result that they expected is not produced. And we may want to say that that is the same as negligence. I'll look at that a little later on. Okay, just want to quickly look at the word iatrogenic. This word is a very old word. coming from the ancient Greeks. Iatros in Greek means a physician or healer. And of course, Genesis means the creation, the cause or origin. So therefore, when there is some harm to a patient because of a medical practitioner, we always say, well, this is iatrogenic. Speaking of the ancient Greeks, we know that the issue to first do no harm, it's a very ancient principle as far as the practice of medicine is concerned. And this is found in the Hippocratic Oath that doctors take at the start of their career. Now, adverse events is directly related to patient safety because where there is an issue of patient safety, where patient safety is breached, this is where you will get an adverse event. So therefore, we know that patient safety deals with the absence or the preventable harm to a patient and in reducing the risk of unnecessary harm associated with healthcare to an accepted minimum. Now, let me just run quickly. One of the things that my studies have shown is that we tend to have patient safety issues among Black people in most of the first world countries. It's higher. We tend to have it in lower income countries. And this is something that we may have to bear in mind. Is it that your social economic status may have something to do with your safety as a patient? Now, let me just give some first legal advice here. One of the things that's going to help you, ladies and gentlemen, is proper documentation. If you see some issue of gap in care, so therefore you as one consultant come to see a patient that another doctor saw and you think that the doctor made an error, do not fight your battles in the docket. All right? Be very careful. Sometimes you may see there may be issues and gaps in care. Maybe the resources may not be there, or maybe you're short staffed. Yes, you want to document these things, but one must always be very careful of what you put in the docket. Remember, the docket is a legal document that will or usually or may be subpoenaed by the other side to see how you conducted yourself in the management of this patient. Where you're short staffed or you have shortage of equipment and so on, that is no excuse not to do your best to help the patient as best as you can. Of course, the Medical Council of Jamaica, in their book, A Guide to Ethical Practice, which I advise everyone to read, it speaks to the fact that there may be professional misconduct charges brought against a doctor if you disregard or neglect your professional responsibilities to patients. So therefore, do not be in a situation where you don't have everything you need and you throw up your hands and walk away. That's not going to save you. Let's talk about the World Health Organization has to say about adverse events. The WHO says, listen, this thing is pervasive, problematic, and it can occur in all settings and at all levels, private practice to the top hospitals. And of course, there are multiple interrelated factors that is going to lead to an adverse event. Some of these included system and organizational factors. We know that more and more nowadays, the practice of medicine is now so complicated with all these new technologies and all these interacting professionals and, there's issue of disruption in workflow, resource constraint, inadequate staffing. All of these are issues that all of us, especially for those who work in the public health sector, face on a daily basis. There may be human factors, such as communication breakdown among workers, communication breakdown between the healthcare professionals and the families, ineffective teamwork, fatigue, burnout, and cognitive bias. Dr. East Miles did a study during the COVID-19 pandemic, which I know called the East Miles Report, which showed that there was a significant level of burnout among the residents in the DM program. And of course, we know that the University Hospital took significant steps to correct this finding. I think they hired about 60-something new doctors based upon the East Miles report. Now, there are also external factors, such as the absence of certain policies, inconsistent regulations, and of course, economic and financial pressures. that may lead to adverse events. Let's look at some of the reportable adverse events that you may encounter. Surgical events, operating on the wrong patient, operating on the wrong site, doing the wrong procedure, retain foreign body after the procedure. I know the latter seems to be fairly common, where a gauze or a lap sponge or a piece of equipment may be left in the patient after the surgical procedure. It may be product or device related, so contaminated products, air embolism. And in the example I used above, I know that some years ago, there was talk that certain brand of urethral catheter that were imported in the island were causing patients to develop urethral strictures. Of course, issues relating to patient protection. What happened when the psychiatric patients abscond? What happened when the patient with dementia abscond? What happens when a patient on the ward commits suicide? Of course, there may be care and management issues such as medication errors. And I think a study showed that medication errors cause more deaths globally than prostate cancer. Mismatched blood transfusions. Of course, there may be environmental factors. Patient may get burned, may get shocked by certain, improperly working devices, or the wrong gas may be administered to the patient. And of course, there are criminal events. There may be sexual assault that occur. There are cases of person impersonating doctors, and there are cases of physical assault. Another piece of legal advice. We must always differentiate, as I alluded to earlier on, that there is a difference between an adverse event and medical negligence. We must also bear in mind that in every procedure or mode of care, there are complications. There are accepted complications and sometimes even expected complications. So, example, you put a person on steroids, you actually expect that this person will have weight gain, that this person probably will develop diabetes, or that this person may develop gastric ulcers. The reality is you may have now to take steps to mitigate against these expected complications. So, for instance, a patient comes in with right lower quadrant pain, tenderness, and guarding, and you go in and you operate and you find a normal appendix. Is that negligence? It may not be the best outcome you expect. And of course, you do an operation, the patient develops an upside infection despite placing pre-op, intra-op, post-op antibiotics and cleaning the patient. That is an adverse event. Is that negligence? And I say, maybe not. Or a simple thing as a person going to a doctor's office or the emergency room with pain, getting a cataflam or a Voltaren injection, and then developing an injection site abscess. Is that negligence? It's an adverse event, but definitely it does not necessarily mean that it is negligence. Now, one of the things that I've stole this phrase from Dr. Carl Bruce up at the University Hospital, because he always says that people do not sue doctors that they like. And I've found this to be my experience as well, that a lot of times when people sue, when people bring lawsuit against doctors, when people react badly to an adverse event, it is because they felt that they were disrespected. They felt that the treatment they got was less than acceptable. They felt that the doctor or the nurse or whoever deal with them strong, and they want their pound of flesh. Because I have seen over my years, adverse events occur. There's a communication between the medical staff and the patient's family. Everybody understands, and it is dealt with amicably. While I've seen some trivial events occur, and it is taken to the highest courts of the land, it's because people want their pound of flesh. Now, some years ago, the team from the university hospital, the urologist, the nephrologist, myself, we visited Barcelona in Spain to do a course. And one of the things I found is that the issue of interacting with the family after a death, the Spanish people have brought this thing down to a science and an art. And therefore, I call what I'm going to talk to you today about the Barcelona approach, right? I call this the Barcelona approach. And let's look at a couple of things that I learned from my experience in Barcelona. How do you approach the patient or the patient's family after an adverse event? Firstly, it requires an understanding of the process of disappointment. You need to have an understanding of the whole grieving process. How do patients and their families deal with grief? There's the whole issue of guilt, and there's anger, and all of these emotions that evolve. And a lot of times, what families try to do is they may feel bad about something they may have done or may not have done, and therefore they're going to quickly try to find some way to put the blame on the doctor or the nurse or the institution. So we have to understand this when we are dealing with family, especially if the adverse event is one that has led to death or some severe disability on the part of the patient. Now, from a legal point of view, and also an ethical point of view, there is no single appropriate response to an adverse event. Each situation has to be assessed, and all the several factors have to be taken into consideration. You have to look and see what you're dealing with and who you're dealing with. Are you dealing with the family of a Don who was known to kill 20 people? Or are you going to deal with that the same way as a very kind and benevolent pastor who is very understanding, right? It depends. Now, many of us as medical practitioners, and I'm sure you'll agree with me that many times you can tell the process patient or the process family member from day one, just by their attitude, the kinds of questions they ask, how they talk to you, you know. You kind of, from early out, can gauge who or what you're talking to. And I think really and truly, the management of adverse events really should start the beginning of the doctor-patient or the medical practitioner-patient interaction. Even before you touch the patient, you should start managing expectations. So you're a plastic surgeon, someone comes to do a breast reduction. You have to let them know that, hey, listen, there's going to be a scar after the surgery. Okay? So they don't feel away when the surgery is done, goes good, but now they have this scar. We have to start, to me, the beginning, even before we touch the patient, by starting to manage their expectations. And I think once we do that, if something happens on the back end, then we already have the basis of a discussion. So there's no single appropriate response to when there's an adverse event. Of course, at the core of the process, ladies and gentlemen, is that we must show empathy, we must show respect, and of course, we must show that our dealing with the patient and or their relatives is totally transparent. One of the things about our Jamaican culture is that we place so much value on respect, to the extent that when you meet a man on the street in Jamaica, you hail him up by saying, respect, boss. And a lot of times I find that when patients bring lawyers and patients get angry and patients get aggressive, it's because they think that they were disrespected. Something to bear in mind. Sometimes we as clinicians, we may say, oh, it's just an MI, or oh, it's just an appendix, man. Oh, it's just a little abscess. We must remember that what may be a routine day in the life of a clinician is the worst case scenario in the life of your client. For a mother to hear that, oh my gosh, your child has leukemia. Oh, we deal with leukemia every day. No, man, don't worry about that, man. No, 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 that's huge. For a parent to hear that the child has an appendicitis and is going to need surgery, or for someone to hear that they're now diabetic. For us, it's like, oh, diabetes is a dime a dozen. Always remember that what may be routine for us may be the worst day in the life of our client. And sometimes when they act out and they act a certain way, sometimes when they even become aggressive or even disrespectful, do not be quick to jump on the defense and attack. You have to be empathetic and realize that it may be the worst day of their lives. Now, another piece of advice is, despite the fact that you want to be transparent and respectful, in any discussion you have with the patients or their relatives, or if the media is involved, you do not want to admit to any legal liability. I'm saying that from the get-go, and I'll get back to that a little later on. And that's just a legal principle. And I always tell people, even if you're in a fender bender or in a car accident, don't make any statement unless you have gone over it with your legal representative, or at least with your head of department or your senior. Now, one of the things that they do in Barcelona, ladies and gentlemen, which I found very interesting, is that they work out in detail how you plan the meeting with the family member. It's a whole science. The first thing is that you have to select the right location. These people go as far as saying that the room must be quiet, the lighting must be soft, it must have a calming effect, and even the color of the room is significant. And I think they do this to say that you want everybody just to be relaxed, all nerves that are frazzled to be calm. That's a key shot. You may not have the luxury of this, but at least you may find a nice side room, or you may find a nice quiet place where you can sit or stand with the family to have discussion. It's important to manage this. Of course, you want to select the right time. So clearly, if a person hear bad news, oh, grandma just died, you may not want to have that meeting with them right away. So the time is important, and you have to have that emotional intelligence to observe the situation, because there are some people who may want to talk to you right away, but there are some people who you may want them to blow off some steam and calm down before. All right. So you want to determine what are you going to be your immediate action. Maybe you want to get them a drink of water. Maybe the person has fainted. You want to check their blood pressure. You want to give them a chair to sit on. Then you want to arrange the meeting. Is the meeting going to be immediate? In a few minutes, in a few hours, maybe the next day? Ultimately, you need to let things calm down. And that's a key shot. Of course, you want to select the right persons to be present. Whether it's a patient, which family member you want to be present. Certainly for me, at my stint at the university hospital, I always try to get the chaplain or pastor present for spiritual guidance, depending on the nature of the case. Psychologist or someone from psychiatry. I always involve the nursing staff. The most senior person on the team, or as senior as possible, should be present. And of course, depending on the situation, you may want legal involved. Now, I always say, if it's something simple, you may not want to get legal involved out front, because then the relatives are going to say, hold on, something is wrong. If you're getting the lawyer involved from now, maybe these guys did something wrong. All right. So you want to use that judgment, whether or not you want legal involved initially. Maybe you can start with a small discussion, see how it goes, and see whether you need to escalate it, whether it's solved at that level. And of course, you want to select the right equipment. I'm not going to advise anyone to hold any meeting or any discussion with any patient or their relatives or anyone, and you are being recorded. Avoid anybody recording you. I say it is better you use a scribe. Have someone that's writing down all that is being said and discussed in the meeting. You will find some very aggressive family members who insist that the meeting is not going on unless they are recording it for their benefit, or unless they want somebody online from the States or from London to be on the phone listening in on the conversation that is going on. You have to use your discretion as to whether or not that is so. Personally, I don't want anybody to record me, but there may be times when you may change. Of course, it depends on the situation. Once this meeting is set up, whatever the circumstances are, one of the first things you have to do is to be genuine. And you have to first offer a genuine, heartfelt apology for what has occurred. Giving an apology, ladies and gentlemen, is not the same thing as saying that I am at fault or I have been negligent. What you're saying is, Mr. Brown, I'm really very sorry for what happened to your sister today. And we share your pain, we share your sorrow. And of course, this is not something that we would have expected. And, be very apologetic. You cannot go into a meeting, you cannot deal with a family member and giving them attitude. People do not sue doctors that they like. You have to be respectful and show the people the respect they deserve. Everybody has to be treated as a star. In fact, if you look at the ethical guidelines from the Medical Council, it speaks to the fact that doctors need to take a human rights approach in their interaction with patients. And of course, this document is online. Just type in Medical Council of Jamaica Ethical Toolkit, and you'll see it. I think every doctor should read it at least once a year. You must have a human rights approach to dealing with patients. Do not be afraid to give a heartfelt apology to the patient or to their relatives regarding the state of affairs. The next thing you want to do is to give a transparent explanation or what appears to be transparent. You don't want to seem like you're hiding anything. And one of the things that I used to do when I'm having such a discussion with relatives, whether they can understand it or not, I would put the docket down and open it up, or put whatever documentation I have in front of the patient and open it up. This is just to say, hey, I come with clean hands. I have an open book. I will show you what is going on. Right? So you want to give a transparent explanation and update in the course of events. Now, these meetings, I can tell you, and I've been at a few, and they can be very emotional. In fact, I would rather do a 10-hour operation that was very difficult than to sit with a grieving family for 5 minutes. It's very emotionally taxing and draining. And I know a lot of doctors run or shy away from it, but it is a part of your job. It's a part of being a clinician. It's a part of treating patients because they have expectations. And when there's an adverse event, when there is harm, they want an explanation and they deserve an explanation. How is my time? Okay. All right. So you must allow the patient and their family to express their feelings. And sometimes they will vent, they will shout, they will curse bad words, and they will say all sorts of things. And you just have to just be calm and say, yes, Mr. Brown, I really understand how you feel. And, you have to be very, very calm about it, right? And this, of course, was embraced by the people in Barcelona. And yes, it's a part of the Barcelona method. You must answer whatever questions they ask. No question is foolish. And if they ask it 5 different times, 5 different ways, answer the questions. You must not leave the meeting until you have landed somewhere, whether it is to plan for another meeting or certain mitigation actions. You may want to indicate to the relatives that, listen, we're going to look into this, the matter's being investigated. Or you may say that, this occurred, we see why it occurred, and we've already taken steps for this to never occur again. That is still not accepting that you are liable. But you just want to show the patients and their relatives that you're not running a party shop and that you're professional. all right? You must always leave an open channel for communication. Now, this is it's subjective because some doctors say, I don't give out my personal number to patients and their relatives. I usually, I guess because of my job as a medical legal consultant, I would give them my business card and say, listen, call me. You can have a representative call me. Feel free if you need to call me. You can always call me. You may or you may not, but you want to provide some channel by which you will be able to communicate with the family. We need to manage the narrative. And too often things come out about hospitals and doctors in the media, and we have no control over it. More and more, I'm moving towards jumping on this thing early, putting out a statement early without even releasing personal information. But I think we need to start managing the narrative because things can go crazy on social media and in the media, as in the Jody and Ferron case. And there are lies that may be out there that you see the lies and you can't do or say anything about it. So you must manage the media. You must manage also the communication channels between what happened on the ward, the consultant, the SMO, the CEO, board, the minister. You also have to manage this communication channel because something may happen in a hospital and the minister may be called upon to explain in public. You need to ensure that the minister has the right information and everything goes through the appropriate channel. You must use this experience as a learning tool. You must use this as a part of your risk management process. You do a root cause analysis, see why it happened. Was the doctor tired? Was the nurse tired? Did the doctor work for 24 hours straight? Was there an issue with labeling? You must find the root cause. You must use it as a teaching and learning tool. But you may also need to make changes, whether you need to send back staff for remedial training. You may need to transfer staff. You may need to send somebody on vacation because this person is obviously burnt out. And I think that's it. I kind of went a little quick because I want to leave space for questions and discussions. So at this time, I'll be happy to answer any questions in the time that's allotted.
Thanks, Dr. Glegg. I would also like to use this opportunity to introduce my co-moderator, Dr. Earl Wright. You raised a lot of issues, and I think it's particularly relevant in the time that we are practicing. Medicine is harder. We have problems. You spoke about gaps in care. You spoke about being short-staffed. You spoke about lack of equipment. And sometimes these don't match up to families' expectations. I like the examples you brought out about incorrect calculation of the dosage of the drug, medication errors, problems with blood transfusions. And again, that statement about when they like doctors highlights the point of communication with families, something I think that we're not always good at. I like your Barcelona model, but these were some of the things that you highlighted that are absolutely important. Another thing that came out, and I'm going straight into that based on a question in the chat about recordings. Because, and the person is asking, how do we deal with overseas family? All right. And and everybody loves to come to the clinic or to meet you with a cell phone recording. How should we deal with that, Dr. Glegg?
Okay, so as it relates to the overseas family, sometimes the person that of interest or the person you may want to talk to is abroad, and therefore you may have to talk to the person on WhatsApp or by a phone call. The first thing I want to say is once you are talking to a person over communication device, the first thing you must remember is always act as if or know that you're being recorded.
Yeah.
And therefore, what you say, you must be cautious of what you say, especially what you admit to. Um, I remember some years ago, a colleague of mine in the States called me. He practiced medicine abroad, but he called me because he was operating on someone and nicked a vessel and the patient lost a lot of blood. And he sent me the report that he wrote. And I know you can't submit that because his report said, while doing the operation, I accidentally cut the XYZ artery. And I'm like, no, what you should say is that while doing the surgery, you notice that there was bleeding emanating from a site, which you quickly dealt with and you stop the bleeding and so on. So a lot of times, why you have to be careful, and you should always, especially if it's a serious case, you should always have your counsel behind you, is because they will tell you how to say the same thing, but not saying it in a way that may be harmful to you. So yes, when you speak to the foreign relatives, if you have to speak to them, fine, but just know that you're going to be recorded. That's one thing. Other thing is that sometimes you also have to manage the expectations of who you speak to, because something may happen. The mother come, then the brother come, then the auntie come, then the grandma come, then the MP come, and you keep on saying the thing over and over and over. What you have to say is, listen, send me one family member or two members, let me talk with them, and then they can share with the other family members as well.
Arna took it one step further, Dr. Glegg. She says asking for cell phones to be turned off can be seen as adverse and might suggest admission of wrong. What plausible reason does one give? When you're meeting them, you say, well, could the cell phones be off, please? How does that, how should we handle that?
Well, that is a right to privacy, and everybody has a right, constitutional right, to your privacy. And you cannot record me if I don't give you permission to record. So even if you notice in this meeting, it says the meeting is being recorded, you have the right to press OK or leave the meeting. So you're saying, listen, I have a problem with being recorded. This is an informal meeting, and therefore, please do not record me. If they insist, well, you're going to have to do some negotiations. If it is a formal meeting, and fine, they want to record, that's it. But if it's an informal discussion, then you have the right to ask someone not to record you. And if they insist, then you will now have to decide how deep or to what extent you're going to engage in the discussion. Because why are they recording it? They're recording because what you say can and may be used against you later on. It may not be admissible in court, but it still can be used against you. Suddenly you see a video of you on Facebook or on Instagram or on TikTok, or your voice on TikTok. All right. So you have the right for that privacy. That's your right.
One more thing. I think this came from Dr. Nemad. And it was a slide you had, which I don't know if you can check back. It said negligence was independent of receipt of I don't remember what this part was. Receipt of remuneration. If that is so, how does that impact the Good Samaritan, right? And he was talking about law and protection for the Good Samaritan. I'll look through that and get the actual details to you.
What that was from the ruling of the DPP, and what the DPP says is that there does not need to be a contractual arrangement. Okay. And sometimes, you know, especially if you're especially in country where you're known in the community, a man may see in the parking lot and say, boy, doc, you know, I have a pain right here. And you may say, oh, I think it looks like that. Why you don't go and sort that out and so on? You have given medical advice. He's acted based upon, because you have now put yourself as a professional. He has sought your advice, and you have given him advice. Though he did not pay you, and though there may not be a contract, you are still held responsible, and that's why you have to be cautious about writing prescriptions in the corridor or in the parking lot. And even as a good Samaritan, you have to be careful, because once you decide to jump in as a good Samaritan, that duty of care will and can still be held against you, though the reality is the court may look at the nature of the circumstances. Because for instance, a dire emergency, the law is very clear. In a dire emergency, the issue of consent, you do not require consent to treat a person in a dire emergency. So therefore, a gunshot wound come in, you're not going to search around for where's the mother, where's the father, who's going to sign this consent form. Or a 5-year-old girl is hit down on the side of the road. You're not going to wait for the parents. You may need to stop her bleeding. All right. So that is very clear in the law as well in terms of emergencies where you can treat without consent. But even then, the court says that though it is an emergency, you are still required to act based upon to the best of your professional knowledge.
I noticed as well, apology. I think there was something that you mentioned about the difference between an adverse event and medical negligence. We need to be clear on that. And at the last, in this latter part of your talk, apology is not an admission of liability. Is that correct? Or an admission of negligence?
That is correct.
Okay.
That is correct.
All right. Dr. Wright, did you see anything in the comments? Please, colleagues, remember the chat is not reserved for requesting your CMEs. We'll do that. But the chat is for questions. Please. It's hard to scroll through all of these requests for CMEs and not get the relevant questions for Dr. Glegg. Dr. Wright, my moderator as well.
I saw Dr. Colette Mary asking, not understanding why Dr. Glegg, the absolute truth, admission of wrong is not being encouraged. I wonder if you could answer that.
No, you're not. You see, you're not saying that you're admitting that you're wrong. What I'm saying is, as an attorney, what I will say to you is that you should not accept liability or admit liability. That is different from saying that something bad occurred. So, and of course, this is where this is what lawyers get paid to deal with. There's a difference between saying you're sorry. There's a difference between admitting that something occurred that may have been adverse than saying, hey, I was negligent. It shouldn't have been done this way. It's a gray area. And this is where you need the guidance. And you have to be cautious in that respect. And that's why I always say, there are cases sometimes where things occur. And I always tell doctors, especially when I'm doing introductory things with the young doctors, say, if something goes wrong, before you talk to the patient or the relatives, go and talk to your consultant. Don't take this on yourself. You gave the wrong drug, or you did the wrong thing, or you did. No, wait, you talk to your consultant, you talk to somebody who is experienced in dealing with patients, because there are ways that you can say the same thing without admitting legal liability. So there's a difference between admitting you're wrong and admitting legal liability.
There was one more question about the difference between handling local patients and overseas individuals. Is there any advice on handling overseas patients?
Well,
and
we all as medical practitioners have at some point in time dealt with the patient who's from the States or from London. I remember a certain consultant at St. Anne's Bay, Dr. Henry Whitelock, he would actually speak to them with whatever accent they came with. And the reality is that they are from a different legal jurisdiction and they have different expectations because they're from a different culture. And their experience or exposure or expectations as it relates to the doctor-patient relationship is different. They're from a first world country and they're from a litigation-rich society. And therefore, their approach will be different. And you have to be aware of that. You have a patient who is from the States. You be prepared from day one. And you start managing that expectation from day one that there's a possibility that there may be a lawsuit. When I take my mom to the doctor in Florida, as I walk in the office, there's a big sign in the office that says, "Dear customers, I have no malpractice insurance." And there's this whole big sign warning you, say, listen, don't think of suing me because there's no money to get. And therefore, it's different cultures. But I will quickly say, Dr. Eckhart, is that Jamaica is getting there now.
I totally agree with you. I totally agree. Orville says, Dr. Nemhard, in his chat, he says, the advice was to use, in talking about apology, he says the advice was to use the term, it is unfortunate, rather than saying, I'm sorry.
Put yourself in the shoe of a patient or the patient relatives. A lot of times they want to feel that you are very unhappy about what transpired. Saying that it is unfortunate is being distant. You're saying that, oh boy, this is really bad that this occurred. And to me, that kind of suggests almost like you're already starting to be defensive. You're already starting
the word. Empathy.
Right.
It has a bit of lack of empathy.
Yes. What you want to say is, and you can say, I am sorry. You can apologize without admitting legal liability. Mr. Brown, I'm really sorry of what happened today. And I share your grief. That is not saying that I'm negligent. And in fact, I think in the same Jody and Ferran case, I had to make a statement to the media. And what my statement was, and I remember it, what I said was, whenever there's an adverse event, doctors are hurt by it. We know the family is hurt. But doctors and medical staff, we hurt too. And we really are sorry that this occurred. And we have to now look into ourselves to see what transpired and to see how, in the end, justice will be served to everyone. That's what I said. Now, in that statement, did I admit any legal liability? I did not. But I did express the fact that we are sorry this happened. And not only is the family hurting, but we, as the medical practitioners, are also hurting because of this loss.
And the last question, some Dr. Will is asking, does it help or hurt to get the complaint put in writing? Does it help or hurt to get the complaint put in writing?
Well, it helps to get the complaint in writing, but what you can also do in the absence of that, you should write down the complaint that is made to you. But there must be some documentation of the complaint. And there are many times I do ask relatives to say, hey, write to me and tell me exactly what happened, what are your concerns. But if they refuse to do that, you need to document it. And something I fail to mention, which is what I always say to my colleagues when they call upon me in a situation, I say, once something has occurred, you go somewhere and sit down and whether type or write down everything that happened in the order that it happened while everything is fresh in your memory, the dates, the times, who you spoke to, who did what, because that is going to be key later on when you are dealing with or addressing the situation. So definitely things need to be documented.
All right. Earl, I'm seeing two quick ones here. What is the best approach if a colleague sees the adverse event as negligent? Should they be silent or should they say something to the consultant? That's one. You want to tackle that one quickly?
They should say something to the consultant, but not to the client. You should go to your colleague, and which is why I alluded to it earlier on, that sometimes doctors fight their battles in the dockets. It needs to stop.
Yeah.
Not that you're sweeping it under the rug, not that you're covering it up, but write the facts before you. Patient scene, this is what it was, this is what I did. You can now go to your SMO and demand a meeting with the SMO and your colleague and say, I think this patient would have been managed another way. This is my opinion. I think you were wrong, and you hash it out. But you can't hash it out in the docket because whatever you hash out in the docket will be open before the court. And that's why you have to be cautious.
Very quickly, I think this one came from our colleague, Dr. Walter. What happens when you think it's because of resource constraints? I'm trying to find it again. I just slipped it. Yeah. She spoke about resource constraints that probably led to the poor outcome. How do you deal with that?
Well, first of all, you have to document and right now, and I think I alluded to it earlier on, that we are practicing in a country with lots of resource constraints. What is key is that you can't just throw up your hands and say, well, I don't have this, so I'm not going to do it. You have to do the best with what you have. You have to protect yourself and protect the patient. So you have to properly document, but you have to be cautious how you document. But you have to document in a way, because what may happen is that your bosses or the higher powers that be may come down on you and say, how did this happen? Why did this happen? You must be able to say, sir, look at page 1, paragraph 2. We did not have any of this drug. We did not have that. We did not have that. Yeah. And so we were forced to use the alternative. But you need to document this because 5 years from now, when all the people who are there has migrated and no one is around. Remember, guys, the statute of limitation is 6 years. Someone can sue you 5 years, 11 months, and 29 days after an event occurred. And therefore, this is why you have to documentation is what will help you. But do the best with what you have. What else can you do? You cannot do nothing.
Thank you, Dr. Glegg. Your talk, this whole disclosure and apology is so relevant. We are in some very challenging times practicing. There are so many take-home messages. I like your Barcelona model. I like your whole idea of apology and empathy and communication, which is something that I think we need to, it's a skill that we have to develop and we have to know how to do it. I thank you so much. Please, listeners, colleagues, remember the chat is for your questions. This is really an important, these topics are most important. Thank you, Dr. Glegg, so much for a really good talk. And I'm going to hand over now to Dr. Earl Wright for our next speaker.
Thank you very much. And good afternoon, everyone. I'm Dr. Earl Wright, and I chair the Joint Medical Council of Jamaica and the MAJ Wellness Committee, trying to reach out and serve all our doctors. It is my great pleasure to introduce Professor Denise Eldemar-Shero, a distinguished expert whose contribution to public health and development have profoundly impacted Jamaica and the wider Caribbean. With decades of experience in gerontology and public health, Professor Eldemar-Shero has been a tireless advocate of evidence-based policies, programs that promote equity and well-being across all ages. Today, she will share her insights on a topic that I'm sure that all of us are interested in, the impaired physician, a transparent and fair process of evaluation and recommended intervention. A topic that underscores our unwavering commitment to fostering accountability, fairness, and solutions in our healthcare and social system. Please join me in welcoming Professor Denise Eldemar-Shero. Professor Shero.
Thank you very much, Dr. Wright. I'm going to get my help now to slide share. Let's see. Share slide. Share.
Remember to put us on slideshow, Denise.
Yes, we're getting there.
Oh, you're perfect.
Thank you very much. May I also thank Dr. Glegg, because I sat here having nightmares. I allow my patients with dementia to record on the basis that they're going to share with the caregiver or the family member, so I'll now have to rethink that. Thank you very much for this opportunity to share, and I am going to focus mainly on doctors with dementia, but it does apply to other impairments, drugs, alcohol, etc. I'm going to cover memory versus executive function for the simple reason that a physician with dementia, you're really focusing from the medical perspective on the function. What should be the process for physicians who have dementia? Or maybe I should say what could, because I'm actually going to ask for recommendations. And importantly, is there a role for earlier recognition of cognitive dysfunction? So an impaired physician is one whose mental or physical health interferes with the ability to engage safely in professional activities. And this definition comes from the American Medical Association. I found it very interesting, and Dr. Wright can remind me what happened to Dr. LaHaye. He wrote about this exact topic in WIMJ in a medical editorial way back in 2005. So we've been talking about this for a while. Annie, come here for me. It's not, I can't see the slides. Sorry, I need some adjustments here. But thanks. So my first question to you is, does your memory loss or does memory loss affect your ability to function? And we could add here, and at what point? The primary difference between age-related memory loss and dementia, because I know some of us are thinking, but I do have some memory. Sometimes it takes me long, I can't find the keys. Age-related memory loss, which really is slowing down, is not disabling. The memory lapses have very little impact on daily performance, and they do not affect the ability to do what you want to do. Dementia, on the other hand, affects the ability to perform. Note that this implies it's more than just memory. And Dr. Greg had a slide which I could insert here where he spoke about persons' expectations that you have a skill set that allows you to do what you're doing. It's very important for us to take into consideration that cognitive function is highly individualized. So you can see where I'm going. It's going to be very difficult to look at this according to age or according to a task. But it's based on health status, experiences, and resources. And I keep on repeating that it's more than memory. It's impacted on by life's experiences, multiple losses, altered sensory function, discomforts with life, retirement, social activities, isolation, and increased dependency, both physical and financial. And as we get older, there are physical impairments. You can't stand for 8 hours anymore. You can't do things that you can't move as quickly as you used to. What this slide is telling us is that cognitive function is something that can be at one point today, another point tomorrow, and come back to the first point. So there, you have to take into consideration depression, a physical illness. So there are many things affecting cognitive function. So we can't assume that somebody that we're interacting with, a colleague or a friend, because they appear to be confused today, has dementia. We need to be very careful about that. So mild cognitive impairment, the term that we're using more and more, it's accepted now in the dementia world, is a general term most commonly defined as subtle but measurable memory disorder. In other words, it is obvious that the person is struggling at times with memory. A person with MCI will have more memory issues than another person who has no MCI. It does not show the other symptoms of dementia, such as impaired judgment or reasoning. Let me reassure anybody who thinks that they might have MCI that most of it will stay as it is. There are no studies proving that it progresses to dementia, although 30% will. Also, as we talk about what to do about the impaired physician, let us recognize the defense mechanisms that are going to come into play. None of us like to think or to be told that we're not functioning at our maximum capacity. And the defense mechanisms are strategies shown in our behaviors, which allow individuals to handle stress and unpleasant situations. Be assured that somebody who is beginning to have early memory issues, such as early dementia, not just MCI, are fully aware that there's something wrong, may not know what it is, and they will do their best to correct it or to deny it. So denial is one of the first defense mechanisms. Displacement, another. Shifting the feelings associated with one object or a situation to somebody else. The docket was wrongly documented, the age or something. In our case, many times the docket can't be found, so you're winging it. and projection, which allows the person to place his or her emotions on others. So if I'm going to be talking about dementia and the way forward with dementia or any form of impairment of a physician, let us appreciate that in dementia, we're talking about a progressive deterioration of intellect, behavior, and personality due to the diffuse disease process. Memory loss in dementia is interesting, and what is important for this presentation is that short-term memory goes first. Many persons with dementia, and this is going to have implications for how one treats a physician with dementia, long-term memory remains for quite a long time into the disease. Impaired judgment, difficulty with abstract thinking, therefore responding in a crisis, responding to an emergency is sometimes difficult. Faulty reasoning. If the dementia has frontal lobe components, you're going to get inappropriate behavior. And there are documented cases of physicians exposing themselves to patients. Loss of communication, disorientation to place and time, gait, motor, and balance problems, neglect of personal care, and even hallucinations. And not everybody with dementia will have all of these points. So as Dr. Wright said, I like my evidence. So we do have local statistics from the 2016 study, which was a subgroup from the 2012 study. We found mild cognitive impairment in 16% of the population, and this paper is in WIMJ. Interestingly enough, this is actually lower than the international finding, which is 20%. In our population, we found that the age group 60 to 69 had a 4%, 70 to 79, just over 10%, and in the over 80, 31%. So we do see that dementia increases with age, and physicians, all medical personnel are part of the general population, and there's no reason to think that this is not the prevalence among the medical professionals. What I found, going back and looking, 80% of the persons diagnosed with dementia had impairment of executive function. So what is this executive function I keep talking about? It's the set of cognitive skills that makes up the brain's management system. It's related to the ability to perform, and whereas its key components do include memory, it's more about the cognitive flexibility to include focusing attention, making informed decisions, inhibition control, and adapting to the new situations, which can be very, very necessary in dealing with patients. What would become clear from this is that when talking about physicians, we're going to have to look at physicians from the point of view of their discipline. Not all physicians, for example, will be faced with daily emergencies, etc. And in fact, the literature is most abundant on physicians, emergency room physicians, and then surgeons. Those are the two that I found a lot of information about. So the state of your executive functioning can influence the medical team's leader's ability to guide and direct the team. This would also apply to physicians affected with alcoholism. This would also affect drug abuse, because that's going to impair executive function, certainly if the person is under the influence at the time. The American College of Emergency Physicians in a 2020 policy paper stressed the need for maximum executive function due to the high intensity nature of the job. And this was the only group of physicians that I could find that have actually started to put a policy of testing in place. Some other studies that I was able to review, the New Haven Hospital tested 170 clinicians, 70 and older, 12 had cognitive impairment. in Canada, which has a good peer assessment program, and I will tell you up front, I lean towards the peer assessment. 22% of physicians over 75 had gross impairment. And an Australian study found doctors over 65, compared to those 30 to 60, had higher rates of notification to medical regulators. So this ties in with Dr. Glegg's presentation. I could not find any studies in Europe, which I found interesting. In a 2018 paper, this author noted that dementia can affect a doctor's job performance because the memory loss reduces attention and executive function. So I think these make the case that we need to take into consideration what happens about how we treat, how the medical council treats an impaired physician. So the process, I want us all, though, to take into note, we do have a process, a legal process, or for patients with dementia. And persons living with dementia can now be declared incompetent so that somebody else can be in charge. It is important for families with persons with dementia to take over things such as signing the pension form, dealing with the bank accounts. I've had several patients who have cleared out their bank accounts themselves, but of course tell you they don't know who did it because they don't remember it. And the process includes the diagnosis, which comes from a physician. So it's a clinical assessment, biochemistry studies, x-rays, neuropsych evaluations. It's a whole set of things. And the Supreme Court has a format for the medical report, and it's the lawyer, the family lawyer, who proceeds to court. The medical report then says there is dementia and the person is not able to function. What is interesting here is that the court then appoints the guardian under the Mental Health Act and based on the medical report. So we have a process. And I think as we go into the discussions as to what we as a country need to do about the physicians, we have to bear in mind that there may be cases where the family has taken action so as to protect particularly finances. But the person is still practicing and nobody knows that this has happened. Why is it important? And I think I've already made the case for that. So what are the barriers? Because there certainly are barriers. Physicians are good at denying, rationalizing, and minimizing their impairments, whatever they are, not just dementia. I think of sight, I think of cataracts, I think of alcohol, I think of drugs. In addition, many physicians are their own physician, and they do not have a primary care doctor to share with or one who could recognize early changes. Physicians tend to go to a doctor when they have to. Surgery, so somebody has to go to get a clearance, etc. Then we wonder how does it come to attention? Colleagues and patients may feel awkward, embarrassed, and confused. Maybe they don't trust their own perception. And most importantly, they're afraid of being seen as mean, malicious, and defaming a friend. So there are going to be barriers to recognition of physician impairment. And then, of course, there's the confidentiality fears. When do you say what? Who do you tell, etc.? And what is the role of family here? And here I speak about impairment in total, but especially dementia. And I'm not minimizing substance abuse problems. We also have to look more and more, especially with there being no retirement age, medical issues as well, strokes, etc. And that's why it's important, whatever we do, whatever we recommend, that it's going to have to be discipline specific, and perhaps, not perhaps, it will need to be case by case. So when you are dealing with cognitive decline in physicians, ethical, legal, and practical issues arise. The big question is who, when, and how to screen physicians if that is agreed on. Let me say right up front, the American Medical Association has said no to this, and it contravenes their law on ageism and targeting based on age. So it's considered discriminatory to want to screen a physician. Apparently, Canada doesn't have that barrier. And are all disciplines the same with regard to cognitive, visuospatial, reactivity, reasoning, and calculation skills? And I say no to that. Some are more highly reliant on these skills than others. Is a neuropsych evaluation available, and is it needed? So we have questions to answer before we can come up with a program. So let me give some approaches to the issue. And the real issue is to stop practicing or not. In the previous presentation I had done, we had talked about how can we get a physician to recognize that they're now impaired. And I'm not sure that we came up with a solution. Some physicians will, some families insist on it. But many physicians want to continue going as long as possible. Many physicians have not prepared for retirement, and they don't want to go home and do nothing. So the areas that we need to consider: what happens if somebody is diagnosed with dementia? Should they be urged to discuss this with colleagues? Because the diagnosis is not going to take place in the workplace. The diagnosis is going to take place when, for whatever reason, the person has seen a doctor. What is the process reactive practice? And if we are saying that persons with dementia cannot practice, taking into consideration that dementia goes through several stages. So you have physicians with mild dementia. Can they practice? We have to decide that. And usually persons are not diagnosed in the early stages of dementia, hence my reason for raising the question about screening. Then you have moderate dementia, and I think that's the group that's going to be the most concerning as to what to do, because in advanced dementia, persons are usually housebound, if not bedbound, and are clearly not able to practice. What is the role for medical counsel? Is there a role in annual registration? Now, I know I said that in the States, they do not allow screening. Interestingly, we now have to be screened along with the general population for car insurance. So we need to look at what happens around the world, and we need to have a group. I suspect the medical council needs a subcommittee to take this presentation, Dr. Gleggs and others, into more consideration to come up with a picture of what to do. But I beg you, don't leave it again as we did in 2005. And I raised the thing about cognitive competency into registration. Screening, yes or no, and I have been going through that. If so, when, without being ageist. Dementia is not related to age per se. Age is a risk factor by getting older, but then I showed you the figures. Only 6% of persons under 70, but by the time you get to 80, you're over 30%. So obviously, I'm coming down against screening routinely. So what happens now if somebody is suspected? You are working with somebody. And by the way, in the USA, it's not just physicians. The medical authorities in the USA have responsibility for all healthcare professionals. Therefore, their rules and regulations apply to nurses, physiotherapists, everybody. Our system is different, but one would hope that since the medical council is leading, certainly on this discussion here, that we also bring in our other councils to see what are their ideas. Other countries, the issue of who holds physicians accountable to a high standard of practice is still being discussed. That said, Hospitals have an obligation to retain only competent physicians. And we've just had the fantastic presentation on what happens if there are errors. I don't think anybody will dispute the fact that somebody with problems with executive function, with problems with decision-making, are more likely to make a mistake than a fully competent person. Other countries are examining how to recertify, and we can only follow what's happening. So since we usually take our lead from elsewhere. Because the executive function relates to skills, certainly the USA, Canada have decided that an exam will not help. If you have somebody there, for example, suspected of impaired function, it is peer group assessment, and it has to be from the discipline, the discipline, so that they can understand what is acceptable for that particular discipline. And the big question is, can a physician with dementia practice? I've already said that you have stages of dementia, and therefore we have to look at this by stages. Long-term memory is retained well into dementia, and therefore can a physician with early dementia who is working in a group, who has checks and balances, still practice? And if they can, what are the disciplines that can still continue, and how long can they continue? And each discipline is going to have to answer its own question on this, or give their own answer, because they are the only ones that know the skill set required. It is important to note that other workers in safety critical jobs have retirement ages. We don't. Police, judges, pilots, air traffic controllers all have retirement ages, and that's based on just an assumption that as you get older, that you're not as sharp on the job. Now, our nurses do have a retirement age. If you're in the public sector, if you're in the private sector, you don't. So do the doctors in the public sector. So we need to look at this as well. Is it a medical board? Is it the medical council decision? The Federation of Medical Boards in the USA notes that cognitive decline is difficult to discern, but can significantly endanger patients' welfare. They make the point that a mistake can cause death. And all of the publications that I read did their presentation similar to Dr. Glegg, and had the vignettes as to in what cases problems took place. Apologies to the surgeons, because most of the papers I could find were the emergency room physicians and the surgeons. I could not find anything on psychiatrists or medical or medicine. And they noted it's been a recurrent theme, which I had raised previously, that not all physicians are able to determine that it's time to retire. And it's clearly more than just a memory assessment. The AMA recommends committees of medical staff to assess, stressing the importance of the peer review. So as we go forward, some of the things that I think are important are a case-by-case approach is one that we should adopt. It's not an issue of age. I have serious concerns on depending on physicians' self-assessment, and how are we in the early stages when a lot of the tests can still be normal, except for whether you're using mini-mental, MoCA, or whichever test you use. What do we do with the physician who has early dementia? That to me is a big problem, because it's not going to be that difficult to deal with a physician who presents with dementia to the point that it's being recognized. But that person probably has 3, 4, 5 years prior to being recognized as having dementia to have been making some mistakes maybe, but certainly to have been struggling with decision-making. So any evidence needs to be evidence-based. We need to decide if we're going to go this route, we have to decide which tools to use, which are appropriate to Jamaica, what are going to be the parameters of the testing. It's clear we need to follow ethical guidelines. This can't be based on emotion. And there's going to be a lot of emotion. None of us want to say to a colleague, it's time for you to stop. But we also need to remember patient safety and be able to say what's the next steps. Some of the programs abroad have ways to phase them out. So they still allow teaching, they still allow mentoring, but then if they're not remembering, are they going to teach the right thing? That sort of thing. It needs to be relevant and task related, accountable, fair and equitable, and most important, transparent. And I guess the overarching thing to this particular slide is patient safety. The oath we all took said, do no harm. And I've mentioned this already, which screening tool, but the preliminary screening should not be cumbersome. The preliminary screening really is an initial test and tells us if further testing is necessary. But the big question here, the elephant in the room, I've already said I don't think it should be everybody. I don't think it should be age-based. So how are we going to identify the physician who is beginning to struggle with memory to the point of it affecting everyday life? There are 8 guiding principles which I shared from the American Medical Association, one of which is physician buy-in. It is based on a very comprehensive educational program of physicians about dementia and how to get persons to accept that their memory is not quite what it was. Now, let me tell you, being tested is not always negative. I think when you get to certain ages, you begin to question yourself. You begin to worry if forgetting the keys or forgetting a word is the start of dementia. I have colleagues, and I'm one of them, that have already done MRIs. I've done 2 so far to make sure that I don't have the brain changes. So it can actually be a good thing because it can reassure you that all is well. So don't think of this testing as only negative. I had a patient who used to come to me every couple of years. She was not my patient. And she used to sit down in my chair and she said, okay, time for you to do that little thing you do with me and ask me the date and all these things so you can tell me I'm fine. So we need to develop a positive attitude, but we're going to need physician buy-in. And these are my references. I found that this topic was hot enough that I was going to share with you the references. And that brings me to the end so that we can have discussion.
Good. Thank you very much, Professor Elderman, for that excellent, as usual, conference sharing with us about the impaired physician, an emotive topic, but something we all have to deal with. One of the questions that I see is someone suspected of mild cognitive impairment, but the team feels that it's impacting their performance in their specialty. How do we deal with it? How do we move with it forward?
I think as we would anybody with cognitive impairment, I think if the team, you see, that's where we need to decide what happens. Who does the team tell? Because if you are in the early stages of impairment, alcohol, dementia, whatever, you're in denial. So who does the team tell? You and I go way back to the 80s when we were talking about this with regard to child abuse. Do you remember those days, Dr. Wright?
Yes,
And
yes.
when I was preparing this, I was reminiscing on that. Who do you tell? And how can you force the person? Because clearly the person, if it is impacting the team, the person needs to be evaluated. No if or but about that. How can you force them to be evaluated? Is, I think, where we are in terms of how to do it.
One of the ways that I tend to think of it is to clearly divide the clinical helping process from the administrative process. And the person's level of functioning needs to be evaluated by the administrative arm, and the treatment arm take up the helping part of the patient. What do you think about that?
I'm going to put a third one in there. You're correct, and I totally agree. But I would also like the clinical arm in there, because I can evaluate somebody who is doing geriatrics or public health. You can evaluate somebody doing psychiatry. And when you think the impaired physician, since we're in this group, look at Professor Bobron, knowing he was going blind and learning Braille so he could continue to practice. So we need that clinical arm in there. And you raise an important point, which I don't think I stressed enough. If we are going to do this, and when we do this, we must have a support structure in place. The treatment arm there is very important. We can't just say to somebody, you have dementia, you can't practice. What are we going to do? Are we going to ensure they're getting that? What else can they do? Because you don't want to just send them home, because then they're also going to be depressed as well, which is going to aggravate the memory issues. So we need programs for them as well. And this would apply to all of the impairments, substance abuse as well. And you know, we raised this some time ago with regard to even our medical students, which wouldn't be dementia, but would be the impairment. In ComHealth, I had a young lady who was cutting, and we simply put her out of medicine, and it has bothered me ever since. What else? What have we done for her?
The support systems.
The support systems are critical. And when we're talking about dementia, the support systems for the family. And it's critical about the support for the family. Because remember, the family, if we say they can't practice, and why, the family is going to come under additional stress, you know. Who told who? Because the person with dementia is not going to recognize that the team picked it up. So somebody talked. So don't forget the family.
Right. There's another question. Is there a process by which family members can report financial abuse of a relative who is suspected of having dementia, and to which entity would this be reported? That's a question in the chat.
There is a process to report, but like a lot of things in this country, after you report, what happens? So I think that if the family, and I've actually done a couple of these, if the family suspects financial abuse, have the physician do the assessments, try to document the impairment, and go the court route.
Okay. Alicia, you're going to help me. Any other
Yeah,
questions?
I will. I noticed Mahiri asked about, she says, dementia is not, no, why is there no retirement age for doctors? And you, Professor Eldermeyer, mentioned that dementia is not age-related, but the risk is older, the older we become. And then you had a slide that said in certain critical professions, right? There, you mentioned a group of professions where they stipulated an age. So what's the story with us?
That we have no age for anything. Canada is the one stipulating ages, and only for critical, they divided, that's where this critical safety came up, that if you make a mistake on the operating table, it's different to making a mistake on the ward, on the medical ward, where the nurse will pick it up, etc., and that it's very time sensitive in some of the disciplines. Emergency room was the other, where people are critically ill. So they do it around critical illness. I think, Dr. Akar, for me, what I would like to see come out of today is that we have a small group and we develop all of this and we come up with a position paper.
I think that's an excellent idea. And why? Earl, can I segue into this comment made by Dr. East Miles?
Go right ahead.
Sharon, in her thing, said that in the UK, every doctor must have an annual appraisal, which is done by a peer. Okay? My question, when you said to develop a position paper, my question, and maybe Sharon could clarify, who is that peer? Because suppose it's a peer who, this is my classmate. I don't want to put him out to pastures yet. And I want him, he's not that bad. I want him to hold on. Or a peer who I don't like a bone in that man. I hate him. Or woman. How does that work? That peer, that evaluation by a peer, to me, poses more questions than answers. And this is why your statement about a group and a position paper, I think, is an excellent idea. What do you think about that?
I think that's very important. And I was trying to find something from the UK because somebody actually raised it with me yesterday. You only have a North American study. So I'm glad something is done. I think, yeah, I would agree with that. And I think that it gave this some thought because, and this is why I'm saying that it has to come through medical council because we only have a few hospitals. So you're going to know everybody. So do we bring in an overseas consultant? Do we do it when the external examiner is here for a DM, especially if you're based on skill sets? And they have all kind of vignettes I was able to find out where they can put the scenarios up on the screen and ask the person to react. What would you do, etc. So there are tools that are being developed for this, but you would have to have the peer there to appreciate if it's right or wrong, but you are correct. And especially in a country as small as ours. England has a large country, so you can bring somebody down from the north to do somebody from the south. Sharon is saying a 360. How will you test clinical skills in a 360? And I value her opinion. I think we have to know that we can test clinical skills.
What Dr. Broomfield is saying, impairment is not limited to older persons. There are physical illnesses that affect competence. Should a full evaluation be done for everyone as a part of registration and licensure?
I deal with the over 60, so can I stick to my topic? And I'm not negating that. But I don't have a comment. But the Canadians found that the younger ones were not a problem. The mistakes, etc. The Canadian studies show that the group 30 to 60 had far less problems. But you know, a group I have not mentioned, and it just came to me as you were talking, patients with Parkinson's and the shaking hand.
Yeah.
Mm-hmm.
Earl, Sandra Williams made a comment. She said peer evaluation in Jamaica is fraught with the possibilities that they are negative and discriminatory. And overseas evaluation is fraught with standards of care and amenities available to them. You know, what they have to practice with is not necessarily what we have here. So that's a valid comment.
It's a very valid comment, but I fear that if we do nothing, we are going to have a major death, and then you'll need Dr. Glegg.
Yes. I think the recommendation about the setting up a committee to deal with this is going to be very important, because I think on an ongoing basis, we see or hear about individuals, but the incidence is higher in the after 65 population So maybe that's the population that we should focus on more. I don't know your thoughts about that. And if you could recommend some of the screening instruments that's generally used, we'd also be grateful.
And I think we need focus groups as well. You know, I'm going back to my evidence base. You can't get away from that. So I think we're getting some useful comments from the chats. I think we must take all the concerns on board, because if we want to get the buy-in, then we have to listen to the concerns. So I think some focus groups with the different disciplines, we can group them. You have the medicine-based ones, you have the others, the surgically based. So I think we can do a couple of focus groups and make sure we have some of the, even some of our DMs in a focus group to find out. Because Earl, you raised that important point. The team quite often is whispering behind the person's back. And I think we need to have a source that they can report without fear of retribution.
Professor Wolf made a comment in the chat that focusing on the over 65 may not necessarily weed out the people who have drug abuse problems, alcohol, for instance, which is a very valid point.
Very valid point. And I tried to thread them through, but as you know, out there, I was told to focus on cognitive.
Yeah, that's fine. And it's important. I think one of the most valuable things, a position paper and stuff, is something that as a council, we need to look into very seriously. Earl?
Well, I'm hoping, thank you again, Professor Sheriff, for this. It's been a very well received presentation. I see a lot of people responding positively in the chat. And I look forward to the Medical Council, MAJ, taking on board the recommendation of setting up a subcommittee, and also not only focusing on the end result, but putting in place all the preventative and supportive things that are necessary to help in this and prevent these occurrences. Thank you again, and God bless you.
And before I say thank you, Dr. Carr, you need the mental health people on the committee.
Oh, yes.
You know, he just put it on without
yes.
that can't work. I mean, we need the psychiatrist, especially for the whole thing on dementia. So, Dr. Wright, this does involve you too.
Oh, yes.
Thank you very much. and I'm sure we'll get there. Thanks. Appreciate it.
Thank you very much.
Thank you so much, Professor Eldermile. All right, Earl. The next one is, we're doing well with time so far. I'm very happy to announce that. And we're grateful to the 998 participants I see registered or I see online for spending this time with us. I hope you're finding that it's well worth your while. I told you it would be good, and I told you that there were topics here that have tremendous relevance. All right, having spent so much time talking about the psychiatrist, we're going to go over now to a famous surgeon. The next talk we're going to have is from Dr. Jeff East, who needs no introduction, really. Dr. Jeffrey East is a graduate of the University of the West Indies. He completed postgraduate training in general surgery at UW in 1987 and went to Savlamar Hospital as a consultant general surgeon and senior medical officer that same year. He is also a fellow of the Royal College of Surgeons of Edinburgh and a fellow of the American College of Surgeons. 3 years later, Dr. East was appointed an associate lecturer in surgery with the Faculty of Medical Sciences at UWI. In 1996, he moved to the Cornwall Regional Hospital as a senior consultant in general surgery and head of the Department of Surgery. This is a position he remained in until his retirement from the government service in 2015. That's at least 20-something years of yeoman service. He continued to work with the Faculty of Medical Sciences as a senior lecturer in surgery until 2021, when he retired from the university. In 2007, Dr. East completed a master's degree in epidemiology with the London School of Hygiene and Tropical Medicine at the University of London and started his research career now, which was cut short with the troubles at Cornwall Regional Hospital. Essentially, this was because of the shutdown of the records department, which was the keeper of all clinical data at the Cornwall Regional Hospital. At this point, Dr. East is an honorary senior lecturer in surgery with the Faculty of Medical Sciences at UWI. He's an assistant editor of the West Indian Medical Journal and a consultant general surgeon in private practice at the Montego Bay Hospital and Hospited in Montego Bay. Dr. East, it is our pleasure to have you as a part of this ethics meeting today. And you are going to speak to us about the physician as the second victim. Over to you, sir.
Thank you. I'm trying to set up Zoom so I can look at my notes simultaneously.
And we want you on slideshow to see the slides.
So Dr. East, in your case,
Ah,
I'm not sure.
Dr. East, I will leave you a message on your phone quickly with the instructions.
All right. So how do I restrict the view that's presented to the audience to just this slide?
All right, so go back come out of slideshow by clicking escape. And then now stop share. Then click on share. And then to the top, go to advance. After you click advance, you will see a menu to the bottom left, I believe. It gives you the option to select the part
Portion of screen.
Yes, exactly. So just use your mouse and block the area so you'll see your notes, but we would only see the slide.
All right, so go back to basic now.
No. After you block that, just click share. Share again. After you would have highlighted that part of the screen.
Okay.
Okay, but you need to work excellent. We're seeing it now.
Okay. Oh dear. All right, hold on. Oh. All right. So I think we're all set. Good afternoon, everybody, again. My topic is the second victim following medical adverse events. So how did I come to be giving this presentation? Something is blocking my notes. Okay, I can move it. So I had noticed that since retiring from the intensity of public practice and full-time employment with the UWI, I have a lot of time to think about life, how I've lived it, how I've acquitted myself in relation to my professional, academic, and personal responsibilities. It is not that I did not think about these things before I retired, but I was not afforded enough time to take those thoughts and feelings to conclusion and to draw with sufficient astuteness the lessons to be learned therefrom. Those of you who are not old enough yet will come to realize that a significant portion of your professional life becomes a blur because you have so much doing that you really don't have time to sit down and reflect. I noticed that I would lie in bed sometimes late at night and remember bad patient outcomes from as far back as 35 years ago. I still remember a patient who died from PE, pulmonary embolism, right in front of me on a ward round after a prostatectomy that I did in Savlamar. No fault of mine, but it's still traumatic. I could recall details of such cases, some of which I was responsible for and some over which I had no control. And the other thing which I find interesting is that you just don't remember your good cases. This apparently is a consistent finding among practitioners, surgeons. I could not remember the good outcomes. You remember occasional ones and some of your big ones, but the vast majority are, unless you are reminded by patients who come back to see you, you don't. It doesn't just drift into your mind. I wondered if I had received counseling from as early as my residency and throughout my career as an independent surgeon, whether I wouldn't have been less distressed at this stage of my life. I expressed the feeling to Professor Aiken in between sessions at the American College of Surgeons Clinical Congress in San Francisco last year, that I and colleagues would have benefited from such a counseling program during my residency and beyond, and hence my presenting this topic. So the objectives of this presentation will be first to define the second victim phenomenon, describe the features and consequences thereof, identify the ways in which individual and institutional lack of support can intensify the suffering of second victims, identify individual strategies for effective coping and recovery, and identify institutional imperatives and strategies for supporting second victims. So the first physician to label the concept of second victim is Albert Wu in 2000. The phenomenon had been described before, not surprisingly, but he was the first person to label it. He described a case in which a colleague resident had missed electrocardiographic signs of a pericardial tamponade in a patient who had to be rushed to the operating theater late that night. In his words, the news spread rapidly. The case tried repeatedly before an incredulous jury of peers who returned a summary judgment of incompetence. I was dismayed by the lack of sympathy and wondered secretly if I could have made the same mistake. And like the hapless resident, become the second victim of the error. The first victim, of course, is the patient. Those of us who trained in surgery at the UWI, and I suspect most other training programs in the 1980s, should be very, very familiar with this scenario that I just described. So Wu's original usage of this label was in relation to medical error, but it is now realized that similar symptoms and consequences can follow almost any adverse medical outcome in which healthcare workers are involved, although to a lesser degree than if the worker is primarily responsible for the patient's care. Hence, Scott et al. Propose a more expansive definition of the second victim phenomenon that recognizes that healthcare workers may also be traumatized by events over which they have no control and in whose treatment they merely participated as a team member. And her definition is as follows: a healthcare provider involved in an unanticipated adverse patient event, medical error, and/or a patient-related injury who becomes victimized in the sense that the provider is traumatized by the event. Frequently, second victims feel personally responsible for the unexpected patient's outcomes and feel as though they have failed their patient, second-guessing their clinical skills and knowledge base. And there's even vicarious traumatization, in which healthcare workers may be traumatized by the trauma of others, particularly those who feel a close connection with friends. Particularly those we feel a close connection to, such as friends and relatives, or with whom we identify, such as colleagues. And this is, for me, one of the strongest reasons why we should not treat our relatives and close friends and colleagues who are close to us as well. We should entrust their care to other clinicians who we trust. What's the prevalence? The general prevalence is difficult it is difficult, if not impossible, to measure general prevalence, as the syndrome varies in intensity by individual, the specific nature of the adverse event, the specialty, the level of responsibility for a case, the definition of second victim syndrome used, and the measuring instrument. But I put it to you based on these quotations that all of us are affected to some extent at different stages of our career. The first is every surgeon carries within himself a small cemetery, where from time to time he goes to pray, a place of bitterness and regret, where he must look for an explanation for his failures. René Leriche. Nurses, pharmacists, and other members of the healthcare team are also susceptible to error and vulnerable to its fallout. Given the hospital hierarchy, they have less latitude to deal with their mistakes. They often bear silent witness to mistakes and agonize over conflicting loyalties to patient, institution, and team. They are also victims. Albert Wu. And finally, from Martinez and Lowe, it should be taken into account that students can also be deeply wounded by adverse events and become second victims. So having spoken about the difficulty, based on some systematic reviews of existing literature, it is estimated that the incidence of significant second victim phenomenon is between 30% and 43.3%. High-risk specialties and scenarios and prevalence by specialty. All healthcare workers, including some that we would not expect, such as pharmacists, are subject to second victim syndrome. But those in specialties in which there is a higher risk of unexpected and sometimes catastrophic events, such as in emergency medicine, surgery, anesthesiology, and intensive care, are at the highest risk. Approximately 25% of emergency physicians, 27% of emergency nurses, 22% of ICU nurses, 22% of surgery residents, 15% of trauma surgeons, and 17% of anesthesiologists reported extreme and pervasive distress in a study by Sachs and Wheaton in 2023. Pediatricians surprisingly also suffer significantly from second victim syndrome, and that is because a child death and suffering, although much more uncommon than it is in the adult clinical disciplines, it is harder to accept. Medical errors, failure to rescue cases, unexpected patient death, and I inserted this one. These are pretty much quotations from the literature, but I inserted this one. Cases in which a very narrow window of opportunity for success is missed, and an intervention ends up creating more severe and prolonged suffering than would have occurred without it. This is not an uncommon scenario in surgery, where the chances of success of an operation are small, but you and the patient are willing to take the risk, but it goes badly and you end up maiming the patient and making them worse off than they were before the surgery. Impact and consequences. Not every healthcare worker responds to adverse events in the same way. It depends on previous experiences and personality and personality type, and availability of support. Personality is actually a big one. Psychologists would explain to us that not everybody is capable of the level of empathy that would make you too disturbed about adverse events. And this is another quote from Wu. In the long run, some physicians are deeply wounded, lose their nerve, burn out, or seek solace in alcohol or drugs. My observation is that this number includes some of our most reflective and sensitive colleagues, and that speaks to personality. Because perhaps they are most susceptible to injury from their own mistakes. So, what are some of the emotional reactions? This comes from a study by Bush in 2020 with a few alterations and with a few additions. I've taken license to do that. Troubling memories and obsessive reenactment. That is actually the highest on the list. What ifs? We keep replaying the event in our minds and almost magically hoping that we can change the outcome retrospectively. Anxiety/concern, anger towards themselves, regret, remorse, distress, fear of future errors, self-doubts, loss of confidence, embarrassment and shame, guilt, sleeping difficulties, grief and sadness. Some second victims may suffer long-term symptoms of depression, anxiety, PTSD, and even suicidal thoughts and actions. And this is a narrative also from Dr. Wu, which sort of puts all of those reactions into context. Virtually every practitioner knows this sickening realization of making a bad mistake. You feel singled out and exposed, seized by the instinct to see if anyone has noticed. You agonize about what to do, whether to tell anyone, what to say. Later, the event replays itself over and over in your mind. You question your competence, but fear being discovered. You know you should confess, but dread the prospect of potential punishment and of the patient's anger. You may become overly attentive to the patient or family, lamenting the failure to do so earlier, and if you haven't told them, wondering if they know. not a narrative. In the absence of mechanisms for healing, physicians find dysfunctional ways to protect themselves. They often respond to their own mistakes with anger and projection of blame, and may act defensively or callously and blame or scold the patient or other members of the healthcare team. This stress escalates in the face of a malpractice suit. In the long run, some physicians are deeply wounded, lose their nerve, burn out, or seek solace in alcohol or drugs. I thought I would just put in something about suicide rate among doctors. In 2005, this is in the US and in Europe, 40%, the suicide rate was 40% among male doctors than among men in the general population, and 130% higher for female doctors than for women in the general population. The good news is that these rates have decreased significantly in those populations. With male doctors now the same as for men in the general population, and female doctors only 24% higher than for women in the general population. And most healthcare institutions in those countries now have strategies to deal with second victim syndrome. So although I'm not attributing this decrease in suicidality to that specific intervention, I suspect that it helps. Cognitive effects: loss of confidence, impaired judgment, and effect on professional practice, of course, loss of reputation, which is particularly important in private practice, and increased risk of errors and adverse events. That's a very important one. A physician in that state, a surgeon in that state, is going to make further mistakes. And of course, as Wu said, when there's litigation, everything is amplified. All of the symptoms are amplified. It is very important to sit down with your indemnity provider to strategize, as Dr. Glegg pointed out. And I think it is important to admit the truth and take your punishment when it is appropriate. But that is under advice from your attorneys if you have an indefensible situation. Or if you feel that the patient is deserving of compensation. It depends on the system you're working in. Some systems allow no fault compensation, but I don't think that is ours. But you may be so moved to recommend that the patient be compensated. I would like to hear what Dr. Glegg feels, how he feels about this at the end of the presentation. Peer reactions that do not help: gossip, telling second victims to man up and get over it, expressing the often untrue observation that I've never had such a complication or outcome. All my surgical colleagues should be familiar with these notes. Giving half-hearted, grudging support, which is usually obvious to the second victim. Wu again. While there is a norm of not criticizing, reassurance from colleagues is often grudging or qualified. One reason may be that learning of the failings of others allows physicians to divest their own past errors among the group, making them feel less exposed. And I've added something on here. It also helps, I suspect, to relieve their own symptoms on the basis that misery loves company. Aggravating institutional structures and reactions. A culture of blame and shame is not a healthy environment for healthcare workers. Not having a program in place to support traumatized employees, and reluctance to increase the appointment of consultants in the government health services so that no one consultant only services exist in the country. I feel very strongly about this. I think the concept of type C hospitals with one consultant well, it used to be just one consultant for the whole hospital. It used to be traditionally a surgeon. I think it is now pretty much accepted that there should be a consultant in each of the 4 major specialties. But it shouldn't be one. I don't think one consultant should run any service, whether it be in a type A hospital or a type C hospital. It is a recipe for second victim syndrome to have services run by a single consultant, not only because they are usually overwhelmed by the demand of the service and therefore more likely to commit errors of omission, but because they are always on call and have no colleagues at hand with which to share the burden of dealing with adverse outcomes. Coping strategies: maladaptive coping, denial, distraction by taking on increased workload, excessive rumination, blaming, decreased self-care, emotional withdrawal, marital dysfunction, anger, self-medication, suicidality. Suboptimal coping: surviving but persistent sadness, loss of self-confidence, loss of interest in performing duties, joyless practice, reluctance to take on challenging procedures for surgeons. Effective coping has 2 components. First, there's problem-focused coping, dealing with the error, the technical aspects of the error. Accept responsibility for a mistake. I have a slight problem with that, with accepting full responsibility for a mistake which was not totally your fault. But we can discuss that at the end. At least you should acknowledge that a mistake happened. Disclose and apologize to the patient, which is not easy. And in the current environment, you could lose your life if you don't know how to do this. Reenact the procedure and conduct an error analysis, definitely. Make changes to practice designed to reduce the risk of error and even improve outcomes from the procedure. Many innovations are born from catastrophe. Work to change the culture of your institution and colleagues if they haven't already done so as regards management of medical error and poor outcomes. The second component of effective coping is how you manage your emotions. Accept that this will be a difficult time. There is no magic wand. Talk to empathetic colleagues and/or access your institutional EAP, your employee assistance program, which, by the way, Cornwall Regional has a very progressive move. Access professional support groups, religious advisor if you are so inclined. Consider maintaining a diary of personal and daily reflections. A diary can be quite therapeutic. Stick with established routines. Engage in healthy behaviors, exercise, healthy eating, pursue hobbies, outside activities. Take time off from work if you need to, and practice meditation and mindfulness. Although you can practice mindfulness as a meditative practice, it is also a good way of giving your ruminating mind a break during your performance of your daily activities. I will expand on that if I am asked. Other coping strategies include changing your specialty to a less stressful one, and there's nothing wrong with that. As long as there's nothing wrong with that. I know people who have done that and have done very well, excelled in the specialty to which they changed. And even changing your profession. Dr. Glegg, no, sorry. I hope you are not offended by that. It was not meant. What to do after an adverse event? First priority is to rescue the patient. If your emotional state precludes rational thought, ask for help. Ask for help from a colleague, from a senior colleague. Once the patient has been stabilized and a plan of management instituted, the family must be addressed. It is then time to address your emotions and feelings. Call a trusted colleague or access your institution's EAP. How to do disclosure? Disclosure of an error to the patient and relatives is stressful and painful for the second victim. It is easier to disclose the cause of adverse outcomes that are not the result of errors, particularly if the patient and family were properly briefed during the consent process. But admitting to an error, which especially if the patient died, is a difficult one. All physicians should seek advice and training on if and how to do disclosure of errors. I think Dr. Glegg outlined a pretty impressive technique for doing disclosure. But I don't think physicians should not wing it. You should get some specific training before you do this, and leave it to senior colleagues who have more experience. If you are in that situation, if you are in private practice, you're alone. Desirable peer support strategies. If your institution doesn't have a formal second victim support policy, which follows, members of a department can nevertheless develop one for supporting their members, their residents, and their students. Peers should always be willing to assist colleagues during and after surgery in which an error was made or an unpredicted event has occurred. Part of that commitment is to maintain a very low threshold for accepting transfers from rural and other colleagues who are distressed. Having worked at Sablamar Hospital as the only surgeon, at one point I was the only doctor in the hospital. Sometimes you ask colleagues to receive a transfer, and it's not because you can't manage it, but it's because of the stress. And our receiving colleagues our colleagues at major hospitals need to remember that sometimes the referring doctor is just maybe too proud to admit to you that that's the reason why they're asking you to take the patient, just to take some stress off of them. Peer counselors should seek training and adopt the following general strategy. Hone your active listening skills. Listening skills are bandied about as if to say it's some magic formula, but you have to maintain active listening. One of the most off-putting things is to be talking to somebody and they're listening, but they're not responding. They're not showing any reaction to what you're saying, any empathy. It is a special technique to listen actively. Be patient and allow the second victim to control the conversation. You need time to spend with the second victim. Manifest empathy and share past similar experiences and explain how you dealt with them and how you moved on. This latter strategy of sharing similar experiences emerges in the literature as the most effective strategy for alleviating second victim suffering. Reassure second victims by acknowledging that all providers are human, that they are not unique in having had such an outcome, that post-procedure morbidity and mortality rates exist because adverse outcomes happen. And as I just want to re-emphasize, the most powerful thing you can do is to share past similar experiences. You've been there, you have done that. The second victim sees and immediately looks at you and gets hope that he will overcome, he or she will overcome. Desirable institutional support strategies. Stage 1, emotional support provided by a trusted colleague or mentor, preferably trained. So this is a strategy that is spearheaded by the institution. Listening and allowing this second victim to control the conversation, must manifest empathy, etc. All of those features that we outlined prior. Stage 2, support by trained peers, which is where a program in which you select specific peers in a department, for example, and train them to support second victims after adverse events. And stage 3 is support by mental health professionals via a formal employee assistance program. And the 4th component of institutional support is proactive staff education. Toolkits consisting of reading materials, PowerPoint presentations, lesson plans, second victim support strategies and resources, disclosure training, and patient and family support strategies with vignettes of real scenarios. Website with content similar to the toolkits described above. This is another way of delivering the proactive staff education. Create policies that encourage transparency, honesty, and respect for patients and colleagues, and colleague healthcare workers alike. Develop policies and procedures for second victim support and resources and implement them. Prognosis, there are 3 outcomes. There are those who drop out. And as I said previously, there is nothing wrong with that. If having dropped out, you enter a productive field of endeavor in which you might very well thrive. Those who survive, and we described the survivors before, those who continue to work, but they lack enthusiasm and they really haven't gotten past the initial psychological trauma. And then those who thrive, those who take the incident, the event, and grow from it. And these outcomes are not cut and dry. Some dropouts may return to the specialty and thrive, or thrive in other settings and endeavors. And interestingly, initial thrivers may later experience all the deleterious symptoms of second victim syndrome, particularly in semi-retirement when they find themselves with too much time on their hands, like myself. How did I overcome my own second victim symptoms? Talking to colleagues, admitting my feelings, and receiving their empathetic support and admission of similar feelings by my colleagues. I considered therapy, but in the end, my colleagues proved a sufficient balm for my suffering. Transcendental meditation is very helpful. It allows your mind, you develop a strategy to relax your mind, to abolish rumination. Mindfulness, which, as I said before, is a way of extending meditation into your daily routines. Becoming a serious student of Stoicism. Nurturing patience with everybody I interact with, including patients. I still have a hyperacute fear of complications, but I'm learning from a younger colleague, one Dr. Dwayne Hall, how being honest and open with your patients from the word go and continuing through to the end of their care can ameliorate that. One of the colleagues who was very helpful to me in my overcoming was the late Dr. Gregory Thomas, and I want to pay tribute to him. Incidentally, the literature reflects that the fact that interaction with sympathetic colleagues was the most effective intervention for coping with second victim syndrome. I've said that before, I just emphasizing it. Final words, and these are all quotations. Physicians will always make mistakes. The decisive factor will be how we handle them. Patient safety and physician welfare will be well served if we can be more honest about our mistakes to our patients, our colleagues, and ourselves. Albert Wu. Healthcare workers who get wrapped up in error and injury, as almost all someday will, get seriously hurt too. And if we are really healers, then we have a job of healing them too. That's part of the job. It's not an elective issue, it's an ethical issue. All of us have had bad outcomes, have made judgments we regret, and have made choices we would now reconsider. Nonetheless, most of our patients have done well and benefited from our care. We have to keep reminding ourselves of this. Viewing this in the context of our entire career keeps it and us in healthy perspective. Thank you very much. And here are the major references.
Thank you so much, Dr. East. That was powerful. That was really powerful. I think all of us, I know many colleagues who are attending can identify with this second victim phenomenon. And it is such a fabulous segue from Dr. Glegg's talk about disclosure and apology. You said so many things that are real, so many things that we continue to experience as those of us who are still practicing in the hospital with all the challenges. Thanks for that very powerful talk. A couple of questions as I go into them. One question says, a patient or patient's relative that accused a medical doctor or health institution publicly of causing hurt of any sort, should they apologize publicly if they were wrong? Or should the doctor institution be able to sue them for the damage they may cause by their actions? What are your thoughts?
That is probably a legal issue. I would prefer if Dr. Glegg answered that.
And you know what's
I would
hard? He not online.
Sorry?
He not online, Dr. East.
Oh,
he had
he's
to
gone.
leave. Unfortunately,
I would be
he sent his apologies.
Yes, I would be careful about embarrassing the patient. I think it would be sufficient in that case to just declare what your position is without requesting an apology. That would be my position.
But they slandered you in public, you know, and they destroyed your character and everything. So why can't we go back in public and apologize?
Yes, as I said, that would be a legal issue. I would take legal advice, and if there's any doubt that you don't have a bulletproof case, you probably should tread carefully.
Accepted. I don't know if maybe Professor Aiken or anybody else could answer. In your talk, Dr. East, you spoke about this employee assistance program. I don't know if we have, and you proudly boasted that Cornwall Regional has that in place. Does anybody know what obtains at UHWI? I'm not sure. Professor Aiken, are you on? Do you know? All right. Sorry, Bill. Dr. East boasted about the employee assistance program. at Cornwall. For those of us who have gone through the second victim phenomenon, and we feel all the stress and we carry the burden, we carry the weight, is there anything at you to assist us?
So sorry, I was muted. I am not aware of anything. But you know, this is such a relevant and timely talk that certainly from a departmental level, you know, surgeons are at very high risk for the second victim syndrome. And therefore, from a departmental level, we should take the initiative and institute some measures to support our colleagues, because every one of us will be a second victim at some point or another, and in fact, on multiple occasions. So even if the hospital doesn't have a formal mechanism in place from a departmental level, I think it is something that, based on Dr. East's presentation, we will definitely ask him to help us formulate something to support our colleagues and ourselves.
I'd just like you to know that it's not the surgeons only feel second victim phenomenon.
Yes, and I made that very clear.
Thank you very much, Dr. East. We all feel it. Dr. Earl Wright, in fairness, are you aware of any such program that we have other than at Cornwall?
There are a couple of programs throughout the different regions, employee assistance programs, implemented at different stages and different success. And that's what's one of the reasons for the Wellness Committee of the Medical Council and the MAJ to try and put in the support necessary for doctors. Dr. East called them the second victim.
Yes.
Dr. Aiken mentioned that everybody gonna have the high stress level at some point. And I look at it that everybody gonna have a mental health problem at some point in their life. And Dr. East gave an excellent outline of the different ways of managing and coming to grips with these problems. And it is always important that what you put in the support system, that individuals don't move from a mental health problem to a mental disorder. And the other part of it, many of our colleagues self-medicate themselves. And we need to put in all the different support and stress level. They should be aware of the ways of managing their stress on an ongoing basis so they don't move to depression, the post-traumatic stress disorder, and the other problems that occur that later on gonna affect how they work and impair their work. So it's very important that the Medical Council and all the different agencies put in the support system to help individuals, that what Dr. East called the second victim and I call individuals with mental health problems. All 990 odd doctors, as they listen to us, gonna have a mental health problem at some point in their life. None of us are going to get away from that, and we need to put in the support. Thank you. That's what I had to say about that.
And the thing is that Dr. East could mention somebody who helped Dr. Thomas, he said, through yours. But I find sometimes that finding a confidant who you can share with is not always easy at the workplace. However, to go to a question, this question says, are there any international or online options for counseling in the second victim situation? Notice this one asking about online options. My experience with the WRHA employee assistants is that they are not that good with medical issues. For example, physician-nurse burnout. What's your take on that, Dr. East? It's in the chat.
On what? The latter question or the...
This latter question, are there any international or online options for counseling in the second?
Yes. Oh, yes, a lot. But how effective they are compared to visiting a real live counselor, I'm not sure. But there's an abundance of of counseling. There, you can even be counseled by AI now. In fact, Ask Claude is a AI counseling service, which some people have said is quite good. So those options are there, but as I said, I don't know of any literature. They're relatively new. I don't know of any literature which compares the sort of detachment that a internet-based counseling system would have compared to a real live counselor.
I wonder sometimes if by doing it, seeking some opinion overseas, you feel that there's better confidentiality.
Yes,
I don't know.
I suspect, yes. Yes.
All right. Okay. Moving on to another comment. This is a rather long one. In Jamaica, maladaptive coping, i.e. blaming of other colleagues, usually results in second victim collegial support and protection when reported to the medical council. The blamed colleague is proven to be correct eventually. How should this be dealt with? Should there be an attempt to training and counseling of maladaptive blaming second victim to improve outcome for future patients, and add more consultants to the field? I think it's a long question, but I think, Dr. Wright, this is basically incorporating what you are saying about the health and wellness and providing a forum or a means for people to discuss these things. All right. Lastly, I won't say who is mentioning this one, but somebody was saying, picking you up. Excellent presentation. Very sobering. Again, my plea for occupational health units in the healthcare system, which include a psychologist as part of the team, or at least an employee assistance program. So when this person is saying that, I get the feeling that we may not have an employee assistance program at UHWI. Not so sure. Any other comments, Dr. Wright?
There's one. Somebody's asking, Dr. East, in your coping mechanism, I noticed that you did not mention prayer.
I did.
He did.
No, I did. I mentioned speaking to your religious counselor. If you are so inclined, remember, religion is a choice.
True.
Okay, so it was answered.
Yeah.
I don't think I see any others, Alcio.
No, I'm actually going down very quickly. How can we be okay, there's one. How can we be assisted in private practice? Is there anything available in the medical association, such as the MAJ, the CCFP, the AGP, or the medical council? Second victim in private practice.
Yes, that's a very, very good question. I'm not sure what the answer is. Maybe, I'm not sure. I'd be willing to look at other models. The thing is, our models are different from those in the US, for example. But in private practice here, you're pretty much on your own.
Well, more food for thought. Earl, the position paper Denise spoke about. Now we're talking about this whole business of the second victim is real. Dr. East, we are grateful to you for a really excellent presentation. We take a lot of it for granted. We don't appreciate sometimes what this does to the actual doctors involved, but thank you so much for a really good presentation.
And I'd like to invite everybody that's online they can send in their recommendations to the medical council as to how the support system, what support system they would like, and see how we can help to implement these support systems. We have a lot of people and we'd love to hear their ideas. We don't have all the answers and we'd love to get the general council, members of the council to give their suggestions. Thanks.
All right, over to you, Dr. Wright.
Yes, so our last presenter, and lots of time, the last is always the best, and I'm delighted to introduce Professor William Aiken, a distinguished urologist and esteemed leader in the medical field. He is head of the Department of Surgery and other areas at the University of the West Indies, Mona, and a prolific researcher with over 55 publications. Professor Aikens brings a wealth of knowledge and experience to our discussion today. His leadership roles, including chairing the Medical Council of Jamaica's Ethics Subcommittee, highlights his dedication to ethical and patient-centered care. We are fortunate to have him present today on the introduction to the general principles of patient safety. Over to you now, Professor Aiken, for your usual excellent presentation.
Thank you, Dr. Wright, for that very kind introduction. So let me begin by sharing my screen. Where is it? Here it is. There you go. Show me.
We're seeing you.
Okay, so good afternoon, colleagues, and thank you to the Medical Council for affording me the opportunity to present on a general introduction to the principles of patient safety. Today, we're going to look at our learning objectives. We're going to look at a historical background, general principles of patient safety, error prevention. We're going to look at locales of risk, and we're going to conclude with some points. At the end of the presentation, participants should be able to state the importance of a culture of safety in patient care, discuss the importance of a systems perspective in understanding patient safety, list strategies for the prevention of medical error, and discuss areas of vulnerabilities to risk. I have no conflicts of interest to declare, but what I would like to say is that this talk is going to be looking at the very broad principles of both patient and staff safety. We're not going to be going into specific methods of medical error prevention with regards to specific things such as wound infections or preventing DVTs or stuff like that. But rather, what I'll be doing is looking at the very, very broad principles of patient safety. But before I do so, let's just look at some World Health Organization key facts regarding patient safety, which I took from their website. 1 in every 10 patients is harmed during health care, and greater than 3 million. Oh, okay, I just suddenly lost my slides there. I'm not sure what happened. Mr. David, I don't know if you could help me. My presentation just suddenly went.
What you should do, just stop sharing.
Okay. Stop sharing. I'm not even seeing the stop sharing sign.
All right, let me help you. Okay, now this time when you share, click on share, and instead of sharing your computer or either desktop, share the specific PowerPoint file. But before you do so, go to your PowerPoint and click escape.
Go to PowerPoint and click escape.
Yes, in other words, come out of slideshow.
Okay.
So that is important to allow you to advance your slide.
So you say come out of escape slideshow, right? I've done that.
Excellent, great. Now back on Zoom, click on the green button that says share, and a menu will come up. When the menu comes up, don't click on either desktop or computer. It depends on if you're using a Mac or PC. Click on the PowerPoint slide itself. Within the Zoom menu, click on the one that shows you your PowerPoint, and that would solve your problem. Are you seeing it? Excellent, that's it. Now go into slideshow.
Okay, thank you, David. My apologies, colleagues. I'm not sure what happened there. So let me go back to the point where I was. So I was saying that according to the World Health Organization, 1 in every 10 patients is harmed during healthcare, and greater than 3 million deaths per year are due to unsafe care. In low and middle income countries such as Jamaica, 4 in 100 people die from unsafe care. Greater than 50% of the harm is preventable, and half of this harm is attributed to medication errors. It is estimated that 4 in 10 patients are harmed in primary and ambulatory settings, while up to 80% of this harm can be avoided. Common adverse events resulting in avoidable patient harm are medication errors, unsafe surgical procedures, healthcare-associated infections, diagnostic errors, patient falls, pressure ulcers. Pressure ulcers is a big one that we see due to the resource limitation in personnel and nursing staff. Patient misidentification, unsafe blood transfusion, and venous thromboembolism. Patient harm potentially reduces global economic growth by 0.7% a year. And on a global scale, the indirect cost of harm amounts to trillions of US dollars each year. Investment in reducing patient harm can lead to significant financial savings and, more important, better patient outcomes. In other words, saving patients' lives. So by way of historical background, we're all aware of the bioethical principle of primum non nocere, first do no harm. Back in the 80s and 90s in the United States, in New York, a media reporter called Libby Zion died after receiving a combination of meperidine and amine oxidase inhibitor. In Massachusetts, Betsy Lehman died after an inadvertent chemotherapy overdose. These two pivotal events are catastrophic events, brought to focus the problems associated with patient harms and started the genesis of studies being done to look at the extent of harm patients experienced while undergoing medical care. So first was a Harvard medical practice study in which 3.7% of patients were found to experience an adverse event, and care was found to fall below an acceptable standard in 25% of cases. This was followed by similar studies in Colorado and Utah, and the findings were very similar. In 1999, the Institute of Medicine published To Err is Human, in which they extrapolated the findings to the entire US population. And it was estimated that between 44,000 to 98,000 deaths occurred per year due to medical error in the United States. Just very recently, John James published a catalog that indicated that anywhere from 200 to 400,000 deaths per annum occur in the United States due to preventable harm. So somewhere between 44,000 and 400,000, there is, we'll find the truth as to exactly how many persons die per year from medical harm. The Institute of Medicine in 2001 published Crossing the Quality Chasm, in which they identified 6 dimensions of quality. And of course, the first dimension was safe care. The other dimensions were timely care, effective care, efficient care, equitable care, and care that is patient-centered. But note, safe care is one of the 6 dimensions of quality care. And then in 2002, the Joint Commission put forward its national patient safety goals to improve patient identification, improve communication among caregivers. It's a big one. Improve safety for high alert medications. Eliminate wrong side, wrong site, wrong patient surgery, what we call never events. Improve the safety of infusion pumps, and improve clinical alarm systems. The National Quality Forum in 2002 published 28 serious reportable events or never events. These are events that should never occur. And among these 28 are these 3, which are the most common: wrong side, wrong site, or wrong patient surgery, retained foreign bodies, which were mentioned earlier, and death due to medication error. So before we look at the general principles, let us look at some definitions. An adverse event is defined as any injury or harm resulting from a medical intervention. An adverse event may not necessarily be due to medical error. So some adverse events do in fact arise from medical error, and those are result in preventable harm. But some adverse events are not due to medical error on the part of the healthcare provider, and these result in unpreventable harm. So for example, if a patient with a known serious allergy to penicillin is given a penicillin tablet and they have an anaphylactic reaction, then that's an adverse event resulting from a medical error that resulted in preventable harm. But if the patient was not known to have a penicillin allergy and was receiving penicillin for the first time and had an anaphylactic reaction and perhaps even died, then that is unpreventable harm. Medical errors are of 2 types: errors of execution, which involves failure to complete a planned action as intended, as a failure of omission, and errors of planning, use of a wrong plan to achieve an aim, an error of commission. A near miss, which is very, very important, and we'll talk about near misses later, because in a culture of safety, a near miss is just as important as a bad outcome. So near miss is an error which does not reach the patient or cause harm. Near misses should be treated as signals that the system needs fixing. And it has been studied, it has been shown that before you have a catastrophic event, you have anywhere from 200 to 300 near misses. So near misses serve as signals that something is wrong with the system, and near misses in a culture of safety should be treated just as importantly as bad outcomes. So when we look at the general broad principles of patient safety, there are some areas that we want to focus on and that we're going to delve into early on. As I said earlier, we're looking at very broad principles here. We're not looking at specific conditions. So in terms of patient safety, the first principle is that a systems approach is taken to looking at medical errors. The other thing is that human factors and human factor engineering is taken into account, and we're going to explain what that means later. Very, very importantly is the concept of a just culture. And a just culture is the antithesis or the opposite of a blame and shame culture. In a blame and shame culture, medical errors or risk will not be reported or will unlikely to be reported, and therefore the risk to safety is much higher. So a just culture in which persons are able to speak up and receive appropriate training, or if necessary, appropriate disciplinary action is a culture that is important. And in a just culture, basically, we differentiate between an unintended error versus negligence versus persons who deliberately go out of their way to create mayhem. Psychological safety refers to an environment in which everyone, regardless of rank, feels empowered to speak up if they see a problem or see any risk that would potentially cause harm. And this is very important to ensuring a safe environment. And then we're going to see that all of this together engenders a culture of safety in which there is a preoccupation with potential sources of risk and failure from the very CEO right down to the person perhaps sweeps the floor. So all members of staff in the organization, regardless of rank, are attuned to safety. So let us talk first about a systems approach. A system, of course, is made up of many interrelated and interacting parts. Error can only be completely understood within the context of the surrounding system. Too often we focus on the individual who may have made a medical error, not understanding that the system and the interaction between the human being and the system is what created the error and not the human being alone. The basic premise of a systems approach to safety is that accidents and errors stem from an interaction of humans and system failures. The systems in which humans operate can either contribute to or help prevent human errors and associated harm. And the key to prevention is to identify and address factors in the system that contribute to or fail to prevent adverse events or to mitigate harm when adverse events do occur. The systems approach expands the focus of analysis beyond the healthcare provider when an adverse event occurs to include an examination of flaws in the surrounding system that facilitated or failed to prevent adverse event. In a well-functioning safety culture, including a clear and just process for distinguishing between unintentional errors versus blameworthy conduct, this is a core component of the systems approach and a high reliability organization. Professor James Reason was the first to put forward the Swiss cheese model of system failure. In the Swiss cheese model of accident causation, this illustrates how small flaws or weaknesses in a system, in different parts of a system, can come together and compromise the system's safety. A system can have multiple layers of defenses, barriers, and safeguards, akin to the slices of Swiss cheese. But when the small weaknesses, the holes in the cheese, line up across multiple layers, their alignment creates an opening through which hazards can pass and cause harm. So when we look at system weaknesses, there are two main categories of weaknesses in the system. They are what are called active failures. And these refer to the lapses, mistakes, and other actions of the people who are in direct contact with the patient. So the people who make up part of the system, when they have lapses or mistakes, or they do things that result in harm to the patient, these are called active failures. But then the other category of system weaknesses are latent conditions. What's a latent condition? Latent conditions are flaws or weaknesses in the surrounding system that make active failures more likely to happen. These may be conditions such as time pressures, or inadequate staff, or inadequate resources, design deficiencies in the physical environment or equipment, leadership and workplace culture issues, and unworkable policies or procedures. Latent conditions may exist for many, many years before an active failure happens and triggers an accident or medical error. Active failures are usually unpredictable, but a proactive approach to safety can identify and address risky latent conditions to reduce the potential for adverse events. So, things like, for example, not having enough staff, people having to work long hours. These are system flaws or rules that and policies that are made that are not workable, and on the floor, people find workarounds for them because they're just not workable, and these workarounds cause increased risk. When we look at human factors, we're talking about the knowledge of the level of knowledge. Is the level of knowledge commensurate with the task that the person is assigned? Skills and technical competence of the individual are the tasks that the individual is required to do, are the individual's skills and technical competence and knowledge commensurate with those tasks. The rules that govern the performance of a task, or the guidelines, evidence-based guidelines, are these being followed? And when there are breakdowns due to human factors, these, as we said, are called active failures. And there can be an error of execution, what we call an error of omission, or there can be errors of planning or errors of commission. This concept of work as imagined versus work as done is a very important concept, because, in management, you have standard operating procedures, you have rules and policies as to how things ought to be done. But the people on the front line who are actually doing the work and who see the problems, the persons who recognize that the rules and policies are not compatible with the efficiency of doing the work. And they may also find that the standard operating procedures, when you have a staff shortage, they cannot be executed with full diligence. So they, instead of doing the work as it is imagined, as it is imagined it should be done, they have to do workarounds to get the work done. And very often these workarounds are due to a clash of priorities or values. For example, there may be just one nurse on the ward or two nurses, and the nurse may know, for example, that a patient needs to be turned every 2 hours. But in order to serve the medication and do all the other things that she has to do, even though she knows that it's a policy to turn the patient every 2 hours, the value of efficiency of getting all the work done versus the value of turning that individual patient competes with each other, and she has to prioritize and choose. And it's in choosing that when you have these clash of priorities or values due to insufficient resources, that this concept of work as imagined versus work as done comes into play. So these workarounds that people have to do because of deficiencies in the system sometimes leads to these active failures and medical errors. Human factors engineering speaks to the concept that errors and accidents result when the sensory and cognitive functions inherent to being human intersect with imperfect tools, machines, or systems. Human factors engineering design principles and processes can prevent errors and accidents. It accounts for factors such as the physical demands, skill, mental workload, team dynamics, and aspects of the work environment. And this is what I was alluding to earlier, because if the engineering of the human factors in the physical environment and in the scheduling and in the number of personnel is not conducive to doing the work in a timely and efficient manner, then people find workarounds. Or if they don't, what happens is that they end up being burnt out, and the mental workload and so on suffers, and team communication and teamwork suffers as a result. So it focuses on how tools and processes work for people in real-world settings. And they design tools and processes that optimize safety, minimize the risk of error, and mitigate potential harm when error cannot be prevented or intercepted. Human factors engineering was initially applied in industries outside of healthcare, such as aviation, and it analyzes various components of the system in which workers operate to identify, prevent, or remedy vulnerabilities and enhance usability and, of course, safety. So this concept of high reliability organizations, or HROs, and hospitals are indeed HROs. So these are organizations that consistently avoid accidents despite operating in very complex, high-risk environments. And these are described as high reliability organizations. And the prototypes, of course, are your commercial aviation industry and nuclear power plants. These are very high-risk environments where a very small mistake can be catastrophic. So what are the characteristics of high reliability organizations? One is that there is a preoccupation with failure. What does that mean? In high reliability organizations, we proactively look at how risks may occur. We look at the systems, we look at how people interact with the system, and we identify prospectively how things may go wrong, and we proactively try to correct those and prevent them. In HROs, there's a default to expertise. What does that mean? In traditional organizations, there is a default to hierarchy. But in HROs, there is a default to expertise, meaning that it is a person who has the skills and the knowledge that HROs turn to try to prevent error, or if there's an error, to analyze it. It doesn't matter if the CEO doesn't agree. It is the expert who is listened to and who is consulted to find out how to prevent accidents and how to analyze accidents when they occur. There's a sensitivity to operations. What this means, in essence, is that near misses are treated just as there's a focus on near misses just as much as there is a focus on bad outcomes. And there is a focus on risks, and more so than outcomes, in terms of trying to identify and mitigate these. So near misses are seen as signals that are that there is a weakness in the system because, as I said earlier, a near miss is a potential signal for something catastrophic happening. There is psychological safety, which allows for the reporting of errors and near misses. So in an environment of psychological safety, people know that they can speak up and that they won't be punished or reprimanded for bringing to light medical errors, no matter who commits them. And they will more readily volunteer their own errors because this culture of blame and shame is no longer present. There is a reluctance to simplify their understanding of work processes and why things succeed or fail. So high reliability organizations do what is called root cause analysis, or what should be more correctly called contribution factor analysis. So when there are adverse events, they don't look at things superficially, but they get to the underlying cause and they ask what are known as the 5 whys. So at each step of the way, when you answer to one why, there's another why. Why did this happen? So, for example, if a resident on call gave a patient, let's say, too much potassium, and the patient had an arrhythmia, and this is discovered, the superficial thing would be to say, okay, this resident erred and he needs retraining and he doesn't understand things. But in a HRO, what should be looked at is the system, and did the system contribute to this? So that resident might have ended up doing that because he was tired. Why was he tired? He was tired because he did a duty in the preceding, a 24-hour duty in the preceding 24 hours and is now working a normal work day. Why is he doing such a long period of work? Because they are short of staff. Why are they short of staff? Because there is not enough funds to employ enough doctors in the system. This is just a theoretical example I'm giving. But what I'm trying to illustrate is that in root cause analysis, you don't just look at the superficial end result. You try to dig deep and see how the interaction of the system with the human resulted in the catastrophe. And finally, HROs are resilient. There is an appreciation of the unpredictable nature of system failures and preparation for the unexpected. So they take this into consideration and they try to design resilient systems. And we will look at examples of some of these resilient systems, such as fail-safe models and automation and computerization that prevents humans from doing things that might cause harm. So there is both a proactive and retrospective methods of error prevention. In the prospective or proactive method, there is what is called failure modes and defect analysis. And this is when organizations think about all the different ways in which errors may occur proactively in the interactions between humans and the systems in place, and proactively make changes to prevent these errors. Of course, a retrospective approach is when an adverse event does occur, and it is important to learn and to modify the system when an adverse event occurs so that it doesn't happen again. And this is where the root cause analysis comes in, or contribution factor analysis, and the 5 whys that I just mentioned. So in this, you dig deep to find out all the contributing factors that cause the error, and then you intervene by closing the loop. It is not important. It is not important enough just to identify what contributed to the adverse event, but you have to learn from it, and you have to fix the system so that the adverse event does not occur again. And the aviation industry does this very well. And so should hospitals. So what is a just culture? So in a just culture, there is a focus on risks rather than outcomes. In the usual culture, it is when a bad outcome occurs that you look at an individual and focus on the individual and try to understand how the individual could have made such a mistake. But in a just culture, there is a focus rather on risk, potential risk that may cause a bad outcome. We don't wait for the bad outcome to occur, but we focus on the risk. And we look at the interplay between humans and the systems. And this has been mentioned before. But specifically, a just culture recognizes that there are different types of behaviors. Most times when errors occur, it is because of an inadvertent medical error, right? It is not because somebody deliberately decided. Nobody came to work that day to say that they were going to cause a medical error. Usually when medical errors occur, it is an inadvertent error that any one of us could make. And what happens in these cases is that previously, in a culture of blame and shame, when an inadvertent medical error occurred, the individual was taken to task. But in a just culture, we recognize that anybody could have made that error. And if we fix the system in a way to prevent that error from occurring, then that is what should be done. We already mentioned workarounds, work as imagined versus work as done, work as done. We need to fix the system to prevent workarounds. The workarounds shouldn't be necessary in a system that's working. Then we differentiate inadvertent medical errors from negligent behavior. And in negligent behavior, for example, in consenting someone, you recognize that you did not perhaps consent the patient appropriately because he did not discuss all the possible potential problems that are likely to occur, maybe up to a 5% risk. So in negligent behavior, again, you don't discipline these people, but you retrain them. Retraining is what is important for negligent behavior. And then reckless behavior is the last category. In reckless behavior, disciplinary action is what is required there, because in reckless behavior, this is where behavior is so egregious that it causes medical error. And this is a minority. This is a vast minority of cases. So a just culture differentiates between these different types of errors and treats them appropriately and eliminates a culture of blame and shame and appropriately disciplines persons when it is called for, but does not indiscriminately discipline people for inadvertent medical errors. So that's what a just culture is. What are areas of vulnerabilities to risk? So in outpatient care, when patients are not adequately educated about their underlying condition, they don't understand their medications, they don't even know the names of their medications. And when they're on a multiplicity of different medications, this is an area of vulnerability to risk. When there's poor communication between multiple healthcare providers providing care for an outpatient or a private patient, and the communication does not take place in a timely manner between different healthcare providers. And so you can have serious errors occurring there because of a breakdown in communication. And then when there's a failure to provide timely intervention or timely review of results. So you take off some blood tests on a patient, but you do not follow up the results in a timely manner, or the results come and sit on your desk, and lo and behold, a week later, you realize that this is something that needed immediate intervention. So these are some areas of vulnerabilities to risk in outpatient care. Clearly, there are a lot more, but these are a few that I decided to highlight. Inpatient care, there hospital-acquired conditions. And there are many, and I won't be going into detail in any of these, but clearly infections, hospital-acquired infections is a big one. And this can be exacerbated by poor hygienic standards, poor hand washing. At a certain institution that I know of, the hand washing rate is 6 to 22%. Let that sink in, 6 to 22%, right? So clearly, if you're in an institution where only 6 to 22% of the staff are washing their hands between patients, then you're going to have hospital-acquired infections. Lack of standardized care or failure to follow guidelines or checklists is another area of vulnerability in inpatient care. So, we have evidence-based guidelines for best practice, and these evidence-based guidelines should serve as a guide to standardized care. But what happens very often is that there is tremendous variation in the care offered because people do their own thing according to tradition and so on, rather than follow guidelines, evidence-based guidelines. And this results in variation in outcomes and puts patients at risk. Failure to use checklists, for example, in the preoperative checklist, to ensure that you're operating on the correct patient, that you're operating on the correct organ, you're operating on the, for example, the correct kidney, or removing the correct leg, making sure that your equipment is working, that you have everything that you need to safely conduct an operation, making sure the x-rays are available so you can look at it in real time. These are all important things that minimize errors. And then the other area where there's tremendous vulnerability to risk is in transitions of care. And what do I mean by transitions? So when a patient is transferred from one hospital to another, or when a patient is transferred from accident and emergency to the ward, if there isn't proper documentation and a proper communication of important points about the care of that patient, and if there is a lack of continuity of care, for example, when there's a changeover in the team, then these transitions in care are potential points of vulnerability where medical errors can arise. And then this fourth area now, and this is particularly relevant to our practice here in Jamaica, care in a resource-limited environment. There are many, many, many instances. We could spend the rest of this afternoon talking about all the various resource limitations that cause us to compromise the care that we give to patients. A lack of adequate blood leading to repeated cancellations of patients for elective surgery. A lack of sufficient ICU beds leading to repeated open heart and brain surgeries being canceled, for example. Having to do workarounds in terms of using an inadequate suture that is not best suited for the particular part of the body we're operating on, because we don't have the availability of the wide cross-section of sutures that we would need. Working in a resource-limited environment definitely leads to lack of a safe patient environment because of these many workarounds that we have to do in a resource-limited environment. And as I said, we could spend the rest of this afternoon talking about the many, many different ways in which this compromises patient safety. So in a safety culture, where there is a preoccupation with failure, there is what is known as failure modes and effect analysis, which simply means that you proactively look at different ways in which the system may fail and in which the human interaction with the system may fail. We mentioned that there is a deference to expertise, there's a sensitivity to operations or near misses. We don't simplify interpretations when adverse events occur. We do a root cause analysis using the 5 whys, and there's a commitment to resilient systems. And what are resilient systems? Well, on this slide, I show you what resilient systems come about. And these are 6 different levels of recommendations to create more safe systems. And we begin with education and training of staff. So anybody doing a procedure or required to do a task must be properly trained and must be fully educated and must have the appropriate skill set to undertake that task. And then there are rules and policies that should be adhered to, but as we see, sometimes these rules and policies themselves are not compatible with the real world experience on the ground and result in workarounds. Then there are reminders, checklists, double checks. So for example, you're transfusing a unit of blood, there are checks and balances and double checks to use. Then there is simplification and standardization, so this removes the variation in the way things are done. And we know that variation leads to medical error. So when you have a standardized way of doing things, which is based on evidence, and you simplify the process, then your human beings are less likely to make mistakes. And then automation and computerization. And finally, forcing functions. What are forcing functions? Forcing functions, for example, you cannot put a nitric oxide tubing into an oxygen outlet. That's a forcing function, or vice versa. So forcing functions provide the highest level of system-oriented mechanisms to prevent active failures. And as we go down this list from education and training, which is just based on the individual, the human, that's not very effective. But at the other end of the spectrum, forcing functions that actually prevent you from making an error. It's impossible to make an error with forcing functions because it forces you to use a particular thing, or you cannot go forward without doing the right thing. These are what forcing functions are. And they depend more on fixing the system rather than focusing on the individual human, because you could focus on the human being until the cows come home. If the system is not fixed and if the system does not prevent errors from occurring, then no amount of education and training or rules and policies are going to prevent medical errors. It's rather the system that we have to focus on to prevent errors. So how do we create a culture of safety? We first of all need to engage our executive leaders. A culture of safety has to be driven from the very top. It has to be driven from the top. It needs to be part of the strategic focus of the institution or the organization. And it has to percolate right down to the person on the front staff. Everybody needs to be aware that safety is an important part of the culture. We need to educate staff in the science of safety, and a talk such as this is a beginning. We need to identify system defects that can lead to patient harm. So focus on the system. Yes, you need to educate and train, but it is the defects in the system, these latent defects in the system, that very often result sooner or later in harm. And then, of course, we have to learn from our adverse events through the root cause analysis, and we need to close the loop by quality improvements whenever we find that there is a problem. And of course, teamwork and communication are critical because it is only in an environment where there is teamwork and good communication where patient safety can thrive. I want to thank you for your attention as we have come to the end of the presentation. Thank you.
Thank you very much, Prof. Aiken, for that excellent presentation. I see in the chat, there are a lot of people saying excellent presentation. They learned a lot from the presentation, well organized, etc. There is a question about high reliability organizations, and are our hospital moving towards being high reliability organizations and just culture organization? Any thoughts on that?
Yes, I have some thoughts on that. So every major tertiary hospital should have a chief safety and quality officer. And that chief safety and quality officer should be at the level of a senior director, at the same level of a medical chief of staff or SMO. That chief safety and quality officer must be adequately resourced with staff, which includes staff that can do data collection, ongoing data collection, can do ongoing statistical analysis and reporting of adverse events and complications in the hospital. And that chief safety and quality officer should have representatives in each department of the hospital, which reports to him. And within each department, they should also have their own safety and quality, representative, so that with this build out, with this organizational structure, and with the chief quality and safety officer being appropriately educated in the principles of safety and quality, this is how you ensure that you have a high reliability organization and the culture is changed. So I think until we do that, there might be piecemeal approaches to quality and safety. But I think it needs to be part of the organizational structure of all major hospitals. All major hospitals must have a chief quality and safety officer who focuses on safety and quality improvements.
Good, thank you for that. I'm gonna ask Elsie to come in and see if there are any more questions, but there's one that says, should situational awareness be taught to medical students and residents in an attempt to reduce risk and of errors? Your thoughts?
Absolutely. I just attended a course at the Royal College of Surgeons in Edinburgh, focused on non-technical skills for surgeons. And situational awareness is the first and preeminent thing that you must have. You must be aware of your environment and your patient and all the factors affecting or that could potentially affect the outcome of your patient. So situational awareness is a very important skill set. And yes, indeed, it should be taught as part of the non-technical training. The studies, the science has shown that when surgical errors occur, it is not it's not technical skills that cause these errors, but these non-technical skills such as poor communication, poor leadership, lack of situational awareness. These are the major drivers of surgical errors, not a lack of technical skill and know-how.
Good, thanks. Go ahead, Elsie. Anything else in the chat?
Yeah. Bill, I don't know if you want to take this one on. It says, should guidelines contain mainly work as imagined? Can guidelines, which are too far from the ideal, be a setup for adverse events?
A very, very good question. So what is recommended is that persons who write rules and policies consult the stakeholders on the ground. So that's a very important principle. While it is important that the leadership of an organization drives the culture and has a vision for improving a culture of safety, in writing guidelines and policies and standard operating procedures, they need to consult with the frontline staff. And the frontline staff need to be part of the writing of the policy guidelines, because they are the ones who know what really happens on the ground. And if you don't include the people who really know what happens on the ground, then you in an ivory tower writing all these rules and policies which are totally unworkable. And this is what causes the workarounds and generates medical error.
Especially when the Eiffel Towers are in North America and elsewhere, and they have no idea of what our resource limited situation is like sometimes. Agreed, totally. Earl, I don't see anything else right now. I don't know if you have anything else.
No, I don't see anything else, but everybody been saying that Prof.
Yeah.
Aiken's presentation was an excellent and informative one. So I want to thank you very much, Prof. And I'm hoping that many of the things that you spoke about, we will implement them in the coming years. Look forward to.
That's the idea. That's the idea.
Good.
I think
Thanks
this
again.
ethics committee has brought out a lot of food for committee. This ethics meeting has brought out a lot of food for thought, which I think the medical council will need to take and act on. And there is a lot. There was somebody in the chat who suggested that with that second victim comment, some of the older retired practitioners could form a group to help with the counseling of the second victim people. Food for thought, things that we can think about. Earl, anything else?
Nothing else. We're going to ask Prof. Johnson now to move with the vote of thanks. Thank you again, Prof. Aiken.
Thank you all very much. Thank you. Good afternoon, everyone. And I am Dean Williams-Johnson, for those of you who don't know, currently registrar of the council, having taken over from Professor Spencer in March of last year. And it is indeed truly a pleasure for me to deliver the vote of thanks following such an insightful and informative webinar, which I'm sure you'll all agree to. First of all, a heartfelt thanks to our chairman, Dr. Milton Hardy, for his very warm welcome and for setting the tone for today's session. We have been fortunate to hear from 4 distinguished and knowledgeable speakers, beginning with Dr. Peter Glegg, who shed light on the important topic of disclosure and apology after an adverse event, situations which we as physicians encounter in various forms in our practice. Take-home points, discuss issues with your seniors, your consultants, and remember that patients do not sue doctors that they like. Patients want you to feel that you understand their grief, and indeed it is okay to say, I'm sorry. Thank you, Dr. Glegg, for your enlightening presentation. We also express our gratitude to Professor Denise Eldemeyer-Shearer for tackling the complex issue of the impaired physician, a fair and transparent process of evaluation and determination for continued practice. Her discussion on how to approach patients with these matters has been invaluable, and the council will certainly have to examine how we can assist in this arena, recognizing that support systems need to be in place, and of course being wary of things like ageism. It's always a privilege to learn from you, Professor Eldemeyer-Shearer. Thank you. Dr. Jeffrey East, thank you for your thoughtful talk on the physician as a second victim. Your insights have reminded us of an aspect of our profession we sometimes overlook. Physicians can too be victims, leading to what you described as maladaptive and suboptimal coping. Thanks for the guidelines for effective coping and how to manage emotions, including talking to empathetic colleagues, religious leaders, keeping a diary, the importance of an employee's assistance program. Congratulations to Cornwall Regional for having this in place. Dr. East Miles, our occupational consultant at the University Hospital, has said that there's a plan to employ a psychologist to that team, which should help with managing issues of a second victim. Thank you for highlighting the need for the support and the importance of having trained peers. We appreciate your discerning, insightful perspective and how you ably and honestly communicated with us. Thank you so much, Dr. East. A special thank you goes to Professor William Aiken. He was the main organizer of this webinar who introduced us in his talk to the broad general principles of patient and staff safety. We're indeed grateful for your instructive presentation and for alerting us to the fact that attention to systems and human factors all play a role. We should all be striving to be working in high reliability organizations and making sure that we have the necessary senior personnel in terms of risk managers to help to investigate, prevent, analyze errors as we practice. Lots of food for thought. Thank you so much, Professor Aiken. And I'm sure you'd like me to thank our MCs, Dr. Earl Wright and Dr. Althea Carr-Stewart. They were wonderful. We really appreciated your guidance throughout the webinar activities. Your excellence, your enthusiasm, and keeping to time were vital and kept the audience engaged and on track. And we also thank you for stepping into this MC role without hesitation. I think we had over 1,000 persons online between the Zoom platform and the YouTube link. And of course, we'd like to thank the organizing team, Professor Aiken again. He's chair of our ethics subcommittee, ably supported by Mr. Colin Virgo, responsible for our PR subcommittee, along with all other team members who contributed today. Thank you to Mr. David Miguel and his team for their seamless IT support, especially in managing the Zoom link and the YouTube option. Your technical expertise has been invaluable. Lastly, I'd like to sincerely thank you, the audience, for your participation and staying the course. It's not easy to sit with us for 4 hours, but we hope the content presented today will enrich your work, and your medical council is delighted to have been able to serve you in this way. On behalf of the team, I will take this opportunity to wish you a good rest of the day and a productive week ahead. Thank you.
Thank you, Prof. And thanks everybody for joining us. Wishing you all the best. God bless. Thank you again, Dr. Eckert, for being MC, and to everyone. God bless. All the best.
Bye. Have a good Sunday.
Okay.